So am I audible? My slides are visible?
Yes, ma'am.
Okay. So good morning, everyone. I don't know how many participants are there. So I will start with the lung carcinoma classification and molecular pathology. Okay. So, sir, can you tell me these are 8 participants and there are more in the waiting area or somewhere, or these are the only 8 people?
There are a few more, but more people will be joining. You can start, ma'am.
Okay. 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 So you are going to handle this. Somebody is entering the waiting room and I don't have to admit them,
Yeah,
right?
yeah, that will manage, ma'am.
Okay. Okay. So,
After your presentation, you can see the chat box. If there is any question and answer, you can respond on those.
all right.
Yeah.
Okay. Okay. So, this is going to be a 1 hour talk on lung cancer classification and molecular pathology. So sit tight. We will be sharing a lot of information in this talk. So if we see lung cancer historical, evolution in lung cancer, we can say that nearly 2 decades ago, lung cancer was just a one disease, and we as pathologists had to, differentiate between non-small cell and small cell lung cancer. That's all was our job. But then in 2005, around 2004, 5, it was almost mandatory for pathologists to differentiate non-small cell lung cancer into squamous and non-squamous histology. And the reasons were clear that it had predictive value because different treatment was offered to people who were squamous histology, different people who had non-squamous histology, they were offered different treatment. So it had predictive value. Okay, and then further on, it was then it was important to classify non-small cell, non-squamous cancers into whether they are oncogene addicted or non-oncogene addicted. So it started from 2004 when EGFR was discovered as a landmark biomarker, and then it moved on to ALK and ROS1 in coming years. So people were asked, we pathologists were asked to tell clinicians whether it is oncogene addicted. That means whether the tumor has EGFR mutation or ALK rearrangement or ROS1 rearrangement. So therefore, they can treat those patients differently in comparison to patients who do not have EGFR ALK ROS1 aberrations, so they are non-oncogene addicted. Then within the past decade or so, you people must be aware that Nobel Prize was given to Dr. James Ellison from MD Anderson and Dr. Tasuku, I think his name is, in Japan, from Japan. They have got Nobel Prize for identifying identifying rationale of immunotherapy. So then in past decade, immunotherapy has entered into the arena of cancer treatment, wherein our role was not only to check for oncogene addiction, but also to check whether a particular tumor is going to respond to immunotherapy or not. So that is what is today we have whenever a lung cancer. So when we say lung cancer, most of the time it is lung carcinoma, pulmonary carcinomas, and mostly it is non-small cell histology. And if it is non-squamous in histology, then we are expected to do molecular testing and also to check for predictiveness of immunotherapy, responsiveness of immunotherapy. So that is our rule. And in future, it is predicted that lung cancer will be divided according to the combination regimes of the therapy. For example, person A is going to be treated by chemo alone, and person B is going to be treated by targeted therapy, and another person will be treated by immunotherapy, and then there are different combinations. So that is going to be the future, because ultimately we know that patient care is the ultimate aim. So it will be maybe driven according to the therapy. So in lung cancer, these are 2 or 3 things which are important to keep in mind, that most of the lung cancers, especially in India, they are advanced stage. diseases. Okay, so when the patient comes into clinic, they are already advanced stage. Surgical resection is not the treatment of choice, and what we have as pathologists is either biopsy or cytology specimens. Okay, so in this talk, I'm going to talk mainly about these two types of specimens. I'm not going to touch resected specimens because of time constraints, and that's a different topic altogether. Okay, and this is going to be the routine practice in most of the labs. So I will be focusing on biopsies and cytology specimens. Okay, and then accurate histological typing is important. As I said, it is not just small cell and non-small cell business. Now we have to, go and further subtype it. Need to triage the material for molecular testing at baseline and during treatment. So it's not just at the time of diagnosis, but nowadays during treatment also we have to check for some resistant mechanisms, right? And molecular alterations so that we can benefit patient as much as possible. So this is the WHO Blue Book, which is released in 2021, and I hope everybody must be having it if they are practicing lung cancer. And my talk is going to be based on the recent most classification of lung cancer. And so these are the entities. So if you see WHO 2021 classification of thoracic tumors, it has a lot of entities. So I'm going to touch only the major, varieties of or types of lung cancer, adenocarcinoma, squamous carcinoma, neuroendocrine tumors, and briefly I'll touch upon new entities. So if we have to see what is the difference between WHO 2015 and WHO 2021, there are a few things which have been incorporated or taken care of in the recent most classification, apart from other features which are majorly, based on resected specimens. These are the three which I have written here. They are related to small diagnostic samples. So in this classification, they have emphasized on genetic testing. So it is must, it is not desirable, it is essential. And then they have given updates on evolving concepts in lung neuroendocrine tumors. So I'll discuss that, and recognition of new entities such as thoracic SMARCA4 undifferentiated tumor. All right. So if we have to combine histology and cytology material in a particular patient, max to max, we will have this much material, right? So if patient has undergone cytology sample as well as, surgical path sampling, then we will have some cytospins, maybe some direct smears from FNA. If lab has facility to make cell blocks, then cell blocks, LBC, some labs prepare LBC. So LBC and biopsy. So this much material we will have, and we have to not only diagnose, lung cancer, but also to test for predictive biomarkers. So we as pathologists, our crucial role is to judiciously use this material in such a way that we can benefit patient as much as possible. So agenda is what? In lung cancer, agenda is not to waste tissue because of the various reasons I have already discussed. So when the things are clear on morphology, there is no need for doing or confirm it, by other methods. Because we know that we need tissue for molecular testing. So that is what is the main aim, that when you see morphologically keratin pearls, when you see intracellular bridges, there is no need for confirmation by immunohistochemistry. So clinical is definitely important. If clinically they say it's primary lung cancer, and if you are seeing this morphology, you can straight away say this is squamous cell carcinoma, right? And if you see glandular arrangement of the tumor with mucin, then also if clinically it is primary lung cancer, then you can say this is non-small cell carcinoma and adenocarcinoma. No need for doing mucin stains or IHC. So in cytology as well as histology, as I said, if you see keratin, orangiophilic keratinized tadpole cells, spider cells, there is no need for doing further IHC or ancillary studies. Similarly for adenocarcinoma, if it is clear cut, then you don't have to do confirmation. Having said that, if you have a slightest doubt in deciding about the lineage, then you should not hesitate in confirming it by doing immunohistochemistry. So therefore, you should not, say that this is NOS, not otherwise specified, if you don't see morphologically squamous or glandular differentiation. So in those cases, when you have a little bit doubt that I'm not sure whether this is adenocarcinoma or it's solid predominant adenocarcinoma or it is squamous cell carcinoma non-keratinizing. In those cases, it is advisable to do definitely IHC, and two markers for confirmation are TTF1 and P40. So most of the times, these two markers sort out most of the cases. There is no need for doing another set of diagnostic markers. So it is advisable to do TTF1 and P40. Both of them are nuclear markers. They have a good visual impression. So TTF1, it comes out to be positive, then we can say this is non-small cell carcinoma, favor adenocarcinoma. And according to the, in resected specimens, we always give percentage to patterns, because we know that lapidic is a very good pattern, very prognostically good pattern, whereas micropapillary and solid are worse patterns. So if you can document that, okay, this is a core needle biopsy, this is adenocarcinoma, and I'm seeing mostly micropapillary patterns, so they can prognosticate that this is a tumor which is going to behave badly, irrespective of the stage, irrespective of the predictor biomarkers. Okay, so this is advisable to document. Then this is another case where it is not clear whether this is squamous or adeno. P40 comes out to be positive, and then we can say this is an SCC favor squamous cell carcinoma. So similar to histology, cytology also, if even if you don't have cell block facilities available, smears can also be IHC'd. Smears can also be stained for antibodies like TTF1 and P40. They work well in cytospens direct smears, and there also one can confirm whether it is squamous or adenocarcinoma. So this is one case which is a young male non-smoker, and this is an endobronch biopsy where you can see this is the lining epithelium, which is little angry looking. Some atypia is there, but then down there is a tumor which is showing crushed tumor cells. They are all basaloid looking. Nothing more is visible. Some inflammatory infiltrate is seen, and this is the mass from where the biopsy has been taken. And this is the zoom in picture of the same tumor. This is normal, bronchial lining epithelium. In some portions, it has gone under metaplasia and showing dysplasia also. But down there, this is a tumor which is showing keratinization. One can see this is keratinized or squamous differentiation at least. But then these islands are wrapped up by these primitive appearing basaloid cells, right? So one would do, P40 and TTF1 if there is a confusion whether this is squamous, adeno, or this is adenosquamous. Then P40 was positive in this case, and this is one more marker. So P40, when it comes positive, you would see clinical requisition form. This is 35-year-old male, non-smoker. You would hesitate to call it as a squamous cell carcinoma, right? Because squamous cell carcinoma usually is an elderly patients, is a disease in elderly patients. They are heavy smokers. So rather than saying this is squamous cell carcinoma upfront, in a young patient who is non-smoker, it is advisable to also think about nut carcinoma. Okay, so this is nut IHC, which is positive in these tumor cells, which are basaloid as well as which are differentiated. So nut IHC was positive diffusely, and this is a case of nut carcinoma. So earlier it was nut carcinoma in the lung, but now they have placed this tumor in thorax, because by the time these tumors present, it is not clear whether they are arising from the thorax lung, or whether they are present in the mediastinum or arising from the mediastinum. So they have placed this into the thorax. And similarly in cytology, purple books, they are released recently in 2022, WHO cytopathology reporting system of lung, where also they have discussed about nut carcinoma. So it is no longer midline. Earlier it was not midline carcinoma, but now there are evidences that these tumors can also happen at the peripheral body sites. So this is nut carcinoma. Technically, it's poorly differentiated squamous carcinoma, but it is totally different genomically from squamous cell carcinoma, but it does show squamous differentiation, as I showed you, abrupt squamous differentiation. But that's only seen in a third of patients. Not all nut carcinomas you would expect to see squamous differentiation. So a high index of suspicion should be kept. Otherwise, you may miss these cancers. And these are, unlike squamous cell carcinoma, these are very, very aggressive tumors, young people, aggressive tumors, and they die or succumb to the disease within 6 months or maybe less than 6 months of their diagnosis. So it is important to know about these tumors and why it is important to know about them, not only for prognostic purposes, but also predictive, because clinical trials are going on where these patients are benefited by giving bromodomain inhibitors. So nut carcinoma genomically has rearrangement with bromodomain proteins. So inhibitors are going to benefit these patients. So that is what is importance of identifying them correctly. This is another case where, glandular differentiation is there, some squamous differentiation is there. So you would like to know whether they are actually squamous or adenocarcinoma. So when P40 positivity and TTF1 positivity is seen in different components of the tumor, then one can suggest on biopsy that, both adeno and squamous differentiation are present. And this raises the consideration of adenosquamous carcinoma. However, making definite diagnosis of adenosquamous carcinoma require resection specimen, because you need to have at least 10% of each component. So it has to be more than 10% or 10%. So that we cannot decide on biopsy or cytology specimen. But if one sees, P40 and TTF1 in different population of tumor cells, then you can suggest a possibility of adenosquamous. This is another tumor where the tumor cells look very, very pink. They have some squamoid, appearance. They have clear-cut margins along in between the tumor cells, and dense cytoplasm. So one would have to guess on morphology. One would say this is squamous, right? But there is no keratin. So unless you see keratin pulse, do not diagnose something as a squamous cell carcinoma. So it is advisable again to confirm it by IHC. For example, in this case, this was not P40 positive. This was diffusely TTF1 positive. So solid predominant adenocarcinomas and pseudo-squamous or pseudo-squamous or squamoid appearing adenocarcinomas do exist. So be wary of the fact in those kind of cases when you are not sure, you have hesitation in calling some tumors as squamous or adeno, please do IHC and confirm the diagnosis. So this was adenocarcinoma. And also make a note that some squamous cell carcinomas in endobronch biopsy, they are seen in vicinity of normal some mucus glands. So do not confuse these as malignant cells. So this is not adenocarcinoma, this is squamous cell carcinoma, which is entrapping submucous glands in endobronch biopsy. And if you think CK7 can differentiate between adeno and squamous cell carcinoma, you are wrong. And, so rather than wasting tissue in doing CK7 and pankeratin, when you are sure about, it is primary lung cancer, it is epithelial lineage on morphology, then do not waste keratin and CK7. And CK7 will never differentiate, because a third or 40% of tumors which are squamous cell carcinoma in lung, they are positive for CK7. For example, this case, which is positive for CK7, and based on CK7, you cannot say this is adenocarcinoma because this was diffusely positive for P40. So it's useless to do CK7 when you are sure this is carcinoma. When you have a doubt that this is carcinoma lung or some other primary, when you are not sure whether this is epithelial lineage, then of course you can do keratin stains, but otherwise not. This is another case, which is a young female, suffering for more than 3 years with bronchoria, and on imaging, it was looking like pneumonia. So clinicians were not sure. They had done biopsy, and this is showing a core of the lung with these tumor cells, which are very bland looking, naive looking. And if you get just this much area of the biopsy, you may, somebody who is just, new in practice, they may confuse it with benign columnar cells of the airways. Okay, so it is very deceptive tumor where tumor cells are very bland looking, but they do show goblet cells and gastric differentiation. So, and here in this biopsy, of course, it is very obvious because this is proliferating tumor. These are proliferating tumor cells, but sometimes the looks are very deceptive of this tumor. So you would tend to do TTF1 and P40, not of course not in this case, but as I said on imaging, it was like pneumonia, and clinicians were not even sure this is cancer. So this was adenocarcinoma, and TTF1 was negative. Pneumocytes are positive as an internal control. Glands are positive, mucin is positive. You don't want anything else to call this as adenocarcinoma. But this is a distinct type of adenocarcinoma in lung, which is invasive mucinous adenocarcinoma or IMA. And in view of TTF1 negativity, you can make a note in your report that non-pulmonary origin or primary should be excluded. But if it is excluded by all clinical and imaging means, then you can say this is invasive mucinous adenocarcinoma of lung, and based on this peculiar morphology of this tumor. So earlier, these tumors were also known as bronchiolo-alveolar carcinoma, and now we have enough reasons to say this is not, and this is IMA. And why it is important to know about it? Because they are clinically different, radiologically different, they are pathologically different, and molecular genomics is also different of these cases. As I said, they are very deceptive on imaging. They are multifocal. Sometimes they are mimicked, metastasis. So they think this is coming from elsewhere, but in other sites there is no tumor. So and pneumonia, of course. So this picture I've taken from WHO, where on gross there is no solitary tumor. This is all consolidation or mucoid appearance. So it looks like pneumonia. It looks like some organizing pneumonia or something else, but not tumor. And these patients, they ooze mucin and then they cough mucin. So that is why they present often with bronchoria. Okay, and if you have to differentiate IMA from non-mucinous adenocarcinoma, because some amount of mucin is present in adenocarcinoma, garden variety of adenocarcinoma, but the goblet cells and that gastric differentiation is not seen. So this morphology is peculiar of IMA. And as I said, imaging-wise, they are different, and cell-wise, they are columnar cells with mucin here. These are non-mucinous adenocarcinoma. They show type 2 pneumocytes. So that is why they are mostly TTF1 and napsin A positive, but IMAs are mostly TTF1 and napsin A negative. So that has to be kept in mind. And they have, as I said, they are multifocal. So they have more aerogenous spread rather than nodal or distant metastasis. Okay. And genomically, they have KRAS mutations and rather than EGFR L-cross. And if you see type of KRAS mutation, which is G12D in IMAs, in contrast to G12C, which is seen in non-mucinous adenocarcinoma. So we know, I hope you know that we have more EGFR. Asians have more EGFR and less KRAS, but Western population show more KRAS and less EGFR. Okay, so in a fraction of non-mucinous adenocarcinomas, we do see KRAS mutations, but that mutation is G12C mostly. But in IMAs, it is mostly G12D mutation. And similarly, fusions are more in IMA in comparison to non-mucinous ADCA. And when we have, in non-mucinous ADCAs, if fusion is there, that's mostly ALK. But in IMAs, it is NRG gene fusion. So this is how they are different from non-mucinous adenocarcinomas. Clinically, as I said, they develop nodal and distant maps rarely, but they have a lot of aerogenous spread. And prognostically, they are not as, if you compare, they have poorer outcome than non-mucinous adenocarcinomas. This is another case which is carcinoma on morphology, and one is not sure whether this is mucinous, whether this is adeno or squamous. TTF1, P40 were done, and it was showing positivity for both the markers diffusely and strongly. So these tumors also exist. These are biphenotypic tumors when you can have non-small cell carcinoma with both TTF1 and P40. So TTF1 cutoff is if you have more than 5% positivity, you are good to go for adenocarcinoma lineage commitment. But for P40, because it can be, positive in other tumors, the cutoff set is more than 50%. So in this particular tumor, P40 was more than 50%, TTF1 was also positive, but it is definitely more than 5%. So these tumors are biphenotypic tumors, and it is important to know about them because they have, high rate of different types of mutations, FGFR1 amplification, and they do show EGFR and KRAS G12C mutation. So that is why, I mean, if you see more than 50% P40 positive, you should not stop there. They are biphenotypic, they are showing TTF1 positivity, so they should also go for molecular testing because they can show EGFR positivity, they can show KRAS mutation. So we have targeted inhibitors for these particular mutations. So these mutations should be checked. This is NOS when P40 and TTF1 are both negative, and we cannot make a diagnosis. And large cell carcinoma is a diagnosis in resection specimens, not in biopsy or cytology specimens. This is another case, which is again P40 TTF1 negative. And now in this case, it is important to decide whether we are dealing with carcinoma or not. For that, keratins were done. It was negative for CK, negative for CK7, but it was positive for SOX2, SAL4, germ cell transcription factors. These two are positive. CD34 was positive. So if you have a case which is non-epithelial, TTF-P40 negative, and these three markers are coming positive, one should suspect about SMARCA4 deficiency. So this is the tumor which is a SMARCA4 deficient. These are normal cells, lymphocytes, endothelial cells, which are positive for BRG1. And this is another family, another protein of this particular family, which is BRM. It is also deleted in this tumor. So this is same as INI1. We are familiar more with INI1, that is SMARCB1. So same family proteins, they are deleted. And if you see the cytology correlate of this tumor, they are pretty undifferentiated. You are not sure whether this is carcinoma or lymphoma, ALCL, or melanoma or sarcoma, right? So these tumors can sometimes show rhabdoid appearance, binucleation, multinucleation, everything we can see. And they are negative for all the markers, first panel markers, they are all negative. And then BRG1 is deleted in these tumors. Another case is this one, which is keratin positive, P40 and TTF negative, okay? And on cytology, this is also adenocarcinoma, or at least non-small cell carcinoma. So there is no hesitation in saying this is epithelial lineage, and you can prove it by doing cytokeratin as well. So one can say this is non-small cell carcinoma. NOS, there is no nothing wrong in that. But if you have BRG1 IHC, and if you do at least 5 to 7% of non-small cell carcinomas, which can show BRG1 deficiency, okay, and in these cases, which are epithelial in lineage, they can show BRM retention, unlike the first case where BRM was also deleted, okay. So I've showed you two cases. First is this one, which is undifferentiated on morphology, undifferentiated on IHC. And they are keratin negatives. They are positive for 34 SAL4 SOX2. They are BRM deficient. But this is the second case where they are epithelial on morphology. They are positive for keratin. BRM is retained, but BRG is deficient. Okay. So this category of tumor is now added in the WHO, and it is important to know about them because they are different tumors altogether. They are very aggressive tumors, and this category of tumors, if you compare with the non-BRG deficient carcinoma, they still have poor prognosis. Okay, and the importance of knowing about them is they are negative for top 3 biomarkers, EGFR, L cross, but they have different types of mutations. So these two tumors, okay, and this thoracic SMARCA4 deficient undifferentiated tumor has been featured in WHO 2021 and WHO Cytology 2022, because on cytology they look pretty undifferentiated, and a high index of suspicion again should be there for making the accurate diagnosis of these tumors. And as I said, this is the same family of proteins. They are tumor suppressor proteins, and when they are deleted, they show tumor. They show they are responsible for tumor development. And importance of SMARCA4 mutation is also they are predictive of immunotherapy, irrespective of PD-L1 and tumor mutation burden status. Okay, so when a tumor is SMARCA4 deficient, one can try immunotherapy and expect responsiveness. So that is what is the predictive importance of identifying these tumors. Some more tumors in cytology as well as histology are pleomorphic carcinomas. So again, like that of adenosquamous carcinoma and large cell carcinoma, pleomorphic carcinoma should be definitely made on resected specimen, but suggestion can be made on cytology and histology specimens. When you see a lot of spindle cells, a lot of giant cells, then one can raise consideration of pleomorphic carcinoma. But again, we need to have more than 10% tumor cells to call definitely some tumor, a tumor as pleomorphic carcinoma. So in this, we can suggest that this is NSCC with giant cell features. So this raises possibility of pleomorphic carcinoma. Coming on to neuroendocrine tumor classification, and we know that in lung we have two grades, low and intermediate grade on one side and high grade on the other side. So they do not transform, meaning to say that typical and atypical carcinoid, they do not transform to small cell and large cell neuroendocrine carcinoma. There is a rigid line because they are genomically different. Okay. So these are two separate blocks of independent entities. On one, we have typical and atypical carcinoids. Genomically, they have MEN1 inactivation and mutations in chromatin modifier genes, whereas high-grade neuroendocrine tumors or carcinomas are these which are genomically deleted in P53. They have mutations in P53. They have deletion in RB1 protein. So these are two different grades of tumor. Okay, so when we have biopsy or cytology specimen from an endobronchial mass, suspicion of carcinoid, so on morphology, we can say in these small diagnostic samples, we can just say carcinoid or neuroendocrine tumor. We are not supposed to grade them, right? Because we don't have the entire tumor in our hand. So WHO 2021 says that we are allowed to say carcinoid, not otherwise specified, in three situations. One is when we have cytology or a small biopsy specimen, we can say this is carcinoid NOS. If you see some mitotic figures, that can be noted down in comment that I'm seeing mitotic figures, I'm seeing necrosis, spotty necrosis or something like that. It raises consideration of atypical carcinoid, but definite diagnosis will go as carcinoid NOS. And there are two more situations where you can see carcinoid NOS. The one is where metastatic, usually pulmonary carcinoids go to metastasize liver. So most often we get liver biopsy, and that's metastatic site. So at metastatic site, we are not supposed to grade tumors in atypical and typical carcinoids. And we can just see this is carcinoid NOS because we don't know what is the situation in the entire tumor of mitotic figures. And when we get just, few blocks or few slides from an entire tumor from outside for consensus of for review opinion, in those cases also we can just say carcinoid NOS. So these are the three areas where we can use a carcinoid NOS. And for carcinoid and typical and atypical carcinoids are diagnoses to be made on resected specimens where we have to count mitotic figures. Ki-67 in thoracic is still desirable. It's not essential, unlike GI carcinoids. So if you compare digestive neuroendocrine tumors and thoracic neuroendocrine tumors, we do not have grade 3. That means if a tumor which is showing more than 20 more than 20 Ki-67 or more than 10 mitotic figures, we jump into large cell neuroendocrine carcinoma, right, straight away, because we don't have NET grade 3, which is there in digestive tract. So that's an evolving area. Maybe next WHO will talk about or will add NET grade 3 because these are rare cases in thoracic, but they exist. These are highly proliferative carcinoid, which At present, they are falling into LC-neck, but this is an emerging variant where morphologically we have carcinoid-like tumor, but they have mitosis, which are more than 10. Okay, and Ki67, if you do, they are 20 to 30%. So we have no other category, so we make them as LC-neck, but they are carcinoids, and it has been seen that they are genomically they are carcinoid like. So we have at present three types of LC-neck. One wherein they are carcinoid like morphologically and genomically, but they have more mitosis, more Ki67. And then we have small cell like LC-neck where they have genomically RB mutations and P53 mutation. In middle, we have LC-necks which have mutations similar to non-small cell carcinoma, for example, KRAS, STK11, etc. So these three LC-necks, does exist, and that is what has been talked about in WHO. If somebody wants to, read about them in detail, it can be a valuable resource to find out the information. And they all have potential clinical implications. All right. So this was all about classification and updates in lung cancer, which has been dealt in recent WHO 2021 and 2022 cytology. And the main aim is to for us as pathologists is to diagnose them accurately, know about or aware about new entities which are there. For example, nut carcinoma and SMARCA4 deficient tumors, they are not as rare as you would think reading WHO books. They actually in practice they come and they exist. So if one is aware about these entities, then we will be able to make correct diagnosis. Typing, subtyping is important in neuroendocrine tumors, and in non-small cell cancer, it is important to test them genomically, and because they all have their predictive power. So after diagnosis part or classification part, I would move on to molecular. That is next part of this talk. So it is no longer, I would want to make it clear that it is no longer restricted to top three biomarkers, that is EGFR, ALK, and ROS1. We have now moved on to multiple biomarkers in lung cancer. And if you see, these are all recent guidelines last year, NCCN 23, ASCO 23, ESMO guidelines. All of them recommend doing at least these mutations or these biomarkers: EGFR, ALK, ROS1, BRAF, NTRK fusions, RET fusions, MET exon 14 skipping mutations, KRAS, G12C, because this is there in non-mucinous adenocarcinoma. G12D is in IMA, and IMA is rare, and we don't have inhibitors to target G12D. So that is why if you are doing KRAS mutation, aim for G12C specifically, because we have inhibitors now in clinical practice for targeting G12C. Then there are some out of out of these, some of them are still in clinical trial. For example, ERB2 exon 20 insertion mutations, clinical trials are going on for targeted therapy, and NRG1 fusions, PD-L1 IHC. So these are the biomarkers. If lung cancer comes, onto your desk as for diagnosis, one is expected to do. If you are sure this is non-squamous adenocarcinoma, then we have to do all these biomarkers. So one would, expect that doing single gene testing is not going to be, successful, because you don't have that much tissue to do one by one. For example, one EGFR, then ALK, then ROS. So that is not possible. So of course, if we have to test so many aberrations, we would like to do multiplex. That means in one sample, all the biomarkers are tested. So that is what they recommended, that it should be included. So ISLC kept guidelines are pending, and they should appear this year. And then they will also definitely include that. So if you see Asia-specific guidelines or guidelines for countries where resources are limited. So in private practice, I I'm sure that it is possible because patients are, able to afford these NGS testing and all those sophisticated tests. But in government setup, if you ask me, patients are poor, and it is not possible to, do NGS testing for all of them. So for those settings, guidelines are there. Separate guidelines are there for Asian countries and countries where resources are limited. They say that since we have more EGFR, so we can start with single gene testing, EGFR L cross, right? So we will be able to pick up in 50% of cases EGFR, and 30 to 40% ALK is at least, 10% of cases, and then ROS1. If one of the biomarkers come positive, then patient can be put on treatment based on that. If those three are negative, then you can go for multiplex NGS testing for remaining biomarkers. So that is what is the guideline for a poor, resource limited countries. So in government setting, we do single gene testing for EGFR L cross, and then if everything comes, these top three are negative, then we will go for multiplex. But in private practice, if patients are able to afford, then you can, directly send everything for all these biomarkers. Okay. And in addition to all these biomarkers, P53 is also advisable to do. So you can do multiplex NGS, include P53, RB, and as many genes as possible, depending on the setup. So, and the important thing here to note is that these biomarkers are tested differently. I mean, this is not just NGS. There are biomarkers which are to be tested by IHC. There are biomarkers which are to be tested by FISH, because that's more, more kind of cost effective, rather than, and more less cumbersome in comparison to doing RNA-seq for fusion. So if fusion has to be tested, do IHC followed by FISH, and if mutation analysis to be done, do PCR or NGS as per the convenience. So, and PDL1 is by IHC. So planning is important from the beginning. If it is a histology specimen, do make multiple blocks or cut upfront multiple slides to use it for IHC, to use it for mutation analysis, etc. And if you have just cytology specimen, even not cell block, then also these smears or the cytology specimens are alcohol fixed. They are good for mutation testing. PDL1 IHC is a problem in alcohol fixed specimens, but if we have to do, mutation analysis, or then they are good for DNA based testing. Fusion analysis can also be done. And IHC, as I said, IHC is also possible on cytology specimens. And if we have cell block that is formalin fixed, then everything can be done on them as a surgical biopsy. Tumor enrichment is key to success, meaning to say that if you have 90% normal tumors, normal cells, columnar cells, lymphoid cells, etc., in cytology specimens or even in biopsy, and 10% tumor, then it is prudent to enrich the tumor by scraping out or by micro dissecting those tumor cells. So therefore, you avoid falsely negative result if that DNA is going for mutation analysis or for NGS. So enrichment is important, and these are different labs I have taken from this paper, which beautifully they have shown that first lab is diagnosis, where HE as well as you cut slides up front for diagnostic stains, TTF1, P40, and PDL1 IHC. ALK is good. If IHC is strongly and diffusely positive, no need for doing, further. But if you want to confirm resources are available, then it can be confirmed by FISH. ROS1 is always have to be confirmed by FISH or other molecular methods. RET is again a fusion, and TRAC is again a fusion. So RET we don't have IHC, but for NTRAC we do have IHC, and that can be used as a screening test. And then if all are negative, then NGS can be tested, but it all depends on which setup you are working or practicing, what are the resources, what is the infrastructure. Depending on that, these all biomarkers can be tested, and tumor tissue can be utilized. Okay, so for real-time PCR, even 5% tumor is okay, but for NGS, at least 20 to 30% tumor content should be available. So this patient, this is positive for EGFR exon del 19 positive. And importance of knowing these is that patient is put on TKI, responded, and then this is the progression-free survival of this patient, which is 14 plus months. But the problem with this targeted therapy is that they develop resistance and they come back inevitably in all the patients. Okay, tumor comes back. And at that time, we have to test for resistant mechanisms. This is another case where the ALK IHC was diffusely and strongly positive, and there is no need for doing confirmation. But if you do it, you have resources available. This is positive for ALK break apart. So importance of knowing this is that patient can be put on ALK TKI and they respond very well. ROS1 IHC, unlike ALK, this is a screening tool. One has to confirm by either FISH or by RNA-seq or real-time PCR. In this case, this was strongly positive, but when it was confirmed by FISH, there was no break apart. So that is why if it is negative, it is a good screening tool. You don't have to, do anything else. But if it comes positive, which is a case in 20% of lung cancers, it comes positive, out of which only 5% show rearrangement positivity. So that is why is the importance of doing second orthogonal method for all ROS1 rearrangement. And ROS1 IHC positivity is also seen in ALK rearranged cases, EGFR mutated cases, right? So it is so non-specific that it can show positivity in other biomarker positive cases. So if you have limited resources, then do ROS1 FISH later on rather than before, and know about EGFR mutation and ALK rearrangement results. So who knows, if it is positive, it may be positive for ALK. Then you don't have to do ROS1 rearrangement. If it turns out to be positive for EGFR mutation, then you don't have to do ROS1 FISH. So that is what is non-specificity of ROS1 in testing. Cytology smears can also be used for FISH, and even if they are immunostained, even if they are Pap and Nicolau stained or direct smears, air-dried Giemsa stained smears, you can just, take out the tumor, because we need for FISH 50 to 100 tumor cells, which are monolayered, well-layered, and that is all. We don't have to sacrifice the entire slide, and it is neither cost-effective nor useful to use the entire smear, because it will take that much FISH probe. So if you just, take out this much tumor area, it will be good to go. For PDL1, as I said, smears are alcohol fixed, so it is very challenging already in cytology smears, and it is alcohol fixed, and the problems are more. But if the cell block is formalin fixed, it is validated against gold standard, then cytology cell blocks can be used for PDL1 analysis. And for PDL1, I'm sure everybody knows that this is tumor proportion score in lung, in which we have to see tumor cells, not the immune cells, and at least 100 tumor cells should be there to record PDL1, because it's a heterogeneous stain. You may miss PDL1 positivity if tumor cells are just 10 or 20. Unlike ALK, where even 10 cells, if they show positivity, it is going to be positive for ALK rearrangement. But PDL1 is a dynamic marker, so we need at least 100 cells. All right, and intensity does not matter. You don't want this much strong positivity, even if it is faintish, but it should be linear, membranous, even if it is partial. Then also it is fine. So TPS is percentage on a scale of 0 to 100%. And cytoplasmic staining is not considered. In cytology specimen, this is another problem, because in cytology, cytoplasmic, membranous positivity diffuses onto the cytoplasm. So it is difficult to say whether it is cytoplasmic or membranous, but in biopsy it is seen. So this is how PDL1 TPS is to be reported. Now coming to the case 1, which was del 19 positive, right? And put on TKI. disease free till 14 months or so, and then patient progressed clinically and radiologically. So what is next? So if you see resistant mechanisms after first and second generation EGFR TKIs, this is another type of mutation in EGFR per se, that is T790M mutation. And the recommendation is that it has to be tested because we have third generation TKIs which can target T790M. Okay. So do we have to do biopsy again? So the recommendation is that these patients are morbid. So if you take, liquid biopsy, that is blood plasma or any body fluid, and if you can check T790M from the cell-free tumor DNA, then it is okay. If it is positive, then patient can be started on third generation TKIs, that is osimertinib. But if liquid biopsy is negative, in those cases, tissue biopsy should be done for knowing about T790M status. Okay. So in this case, this patient's plasma was subjected to ddPCR for T790M and it was responded to advanced generation TKI, and they can be, followed up on advanced generation TKI. Now, what happens is that and liquid biopsy in cytology. So liquid biopsy is not just restricted to blood plasma. Even if it is urine, even if it is CSF or other body fluids, effusion, supernatants, they are all, good resources for extracting out cell-free DNA, tumor DNA, and that can be exploited to use as a marker, as a tool for T790M mutation detection or other downstream analysis. So this is one thing about liquid biopsy. And now, okay, so T790M is actually important when patient is put on first and second generation TKI. Nowadays, advanced generation TKI, that is osimertinib, is recommended for first line setting. So the importance of recognizing T790M has gone down because in private practice, I'm sure patients are taking osimertinib in first line setting. So T790M does not occur in these patients as a resistant mechanism. Okay, but if patient is on first generation TKI, then of course T790M detection is important. Okay. Now, hypothetically, if this patient again, okay, is negative for T790M mutation in liquid biopsy, then what is next? So as I said, tissue biopsy has to be done. But in this patient, pleural effusion was present. And this pleural effusion was showing nothing but small cell carcinoma on morphology as well as on IHC. So this patient is adenocarcinoma, which was progressed on TKI, T790M was negative, and it has transformed into a small cell carcinoma. So this is another mechanism of resistance. So T790M is most common, but then these are the patients which can transform into small cell carcinoma. So as I said, osimertinib, now with the approval of osimertinib first line setting, T790M is not a problem, but there are other resistant mechanisms in which different types of EGFR mutations like C797S, then there are BRAF mutations, HER2 mutations, and of course, small cell transformations, squamous cell transformations. So these are the resistant mechanisms for osimertinib. So, and these are the different types of mutations, out of which MET amplification is the most common one. So the recommendation is made to do liquid biopsy and to do multiplex NGS rather than doing just single gene testing, that is EGFR. Because we know now that there are different types of mechanisms, PIK3CA mutation, then there are HER2 amplifications, BRAF mutations, KRAS mutations, etc. They can also be resistant mechanisms, and we have now inhibitors to target these resistant mechanisms. So it is imperative, if you are taking liquid biopsy, test it for, multiplex genes rather than just EGFR, and then you find out what is the mechanism of resistance, and then patient can be treated accordingly. But if liquid biopsy fails to, give you answer, then in those cases, tissue biopsy has to be done. And another added advantage of taking tissue biopsy in progression, in patients who are on progression on TKI, is to recognize transformation, because that cannot be recognized by doing liquid biopsy. So in for example, this case where pleural effusion was sent, and this was actually small cell carcinoma. right? So small cell and sarcomatoid carcinoma, squamous cell carcinoma, they are another types of resistant mechanisms, and they can be solved only on tissue biopsy. Okay, so and then the therapy is entirely different if patient is on, patient is a small cell carcinoma turned into small cell carcinoma, or squamous cell carcinoma, or sarcomatoid carcinoma for that matter. So therapeutic management is entirely different. So that is what is recommended and advisable, and we have to, make efforts to give as much information as possible to patients for their therapeutic benefit. So in sum, I would say that we have WHO guidelines to help us, and as I have talked about small diagnostic samples, biopsy and cytology, they are the most common specimens in lung cancer we get. So accurate typing and how we triage the sample, how we judiciously use this sample, and now we know that we have more than 5 biomarkers, at least 10 biomarkers in hand to be tested, mandatorily. So we have to, judiciously use these specimens so that we can maximize, we can utilize and maximize the information from the minimum amount of tissue available to us. So that is all. I would say thank you for your kind hearing and patience. And these are two of my books, which one can refer, or one can um, this is not related to lung cancer, of course, but they are fully illustrative books on thymic pathology and sinonasal pathology. So I just got a chance to advertise my books. Thank you very much.
Aman, can you just show me the PPT once, the first slide? Yeah, good morning, everyone, and thank you for joining this session. I thank Dr. Neeraj and Melap for giving me this opportunity. So I'm sure you must have had wonderful talks from my colleagues in the morning on soft tissue and lung cytopathology. So I am a geopathologist, and when this opportunity was given to me, I thought probably I'll update uh, regarding the renal cell carcinomas, the classification of which has drastically changed in last 2 to 3 editions. And in 2016, there were a couple of new entities, and 2022, this expansion has been enormously increased, including very new recent molecular RCCs. So what I'll do in brief 45 minutes, I'm going to touch down upon the main changes which have happened between 16 and 22 from the expansion of conventional RCCs to the newer entities. So it will be a brief introduction to the new entities. We won't be going into many details, but yeah, we'll be touching the main molecular alterations, morphology, and how to pick up and differential diagnosis. So without ado, I think I'll start and I'll stop sharing my video here so that we can have a look here at the presentation. All right. So Aman, I am again not able to change the slide. Can you please change to the next slide? Yeah. So when we talk about the classification of RCC, conventional RCCs, if we know, the classification has been either based on cellular features like clear cell, papillary, or chromophobe, or the main architecture like whether it's papillae or tubules, or it has been based on anatomic location, where if it is arising from medulla, renal medullary carcinomas, collecting duct carcinoma, associated diseases like acquired cystic disease, associated RCC, and of late, in last decade or so, I'll say 15 years or so, since the molecular came into picture, we have had molecularly defined RCCs. So in 2016 also we had MIT family translocation RCC. You must have heard about TFE3 associated RCCs, and also FH and SDH deficient RCCs. So they have been on the horizon, but in 2022 they have been now clubbed together into a separate category of molecularly defined RCCs. Next slide. Please change next slide. Hello. Yeah. So as I said, this is again to re-emphasize that there have been expansion of RCC classification. So in 2016, there were 14 different type of RCC. In 2022, there are more than 21 type of RCCs. Next slide, please. Next. Next. So this is a preview of the 2016 classification in which couple of new entities were there: MIT family translocation RCC, SDH deficient RCC. I'm sure you must have encountered sometime in your practice these kind of RCC, and probably if you had IHC, specific IHC or genetic markers available, testing available, you could have picked it up. Otherwise, they are actually have specific morphological criteria, and if you know, you can easily pick them on morphology also and then confirm it with diagnostic molecular assay. Next slide. So this I've already emphasized. Next, please. Yeah, again to highlight, these were the new entities which were in 2016. And before we come to the business end of this main business of this talk, which is 2022, I want to know you to all understand that these are entities have been there in 2016, and some of them their nomenclature has been changed, and we'll come to that. Next. So this is the 2022 WHO. I'm sure you all must have a soft copy access to this, or maybe hard copy. So essentially, the main categories have been same: the clear papillary oncocytic collecting ducts. They constitute more than 90% of the RCCs encountered in a practice. However, 5 to 10% do have morphological features which do not fit into this classical type, and that is the aim of this talk, that you should pick up these and learn the morphological and molecular underpinnings of these type of entities. So I'll be focusing main on some of these molecularly defined RCCs which have newly added, and some other entities like SRCC which has been added in this is WHO, and some nomenclature of papillary RCC which has been changed. Next slide, please. Yeah, this is again next. Next slide. Yeah, this is again to re-emphasize that more than 90% of tumors which you encounter in your practice will be falling into clear papillary chromophobe and oncocytoma. But rest 5 to 10% you should be able to pick up because they have different kind of prognostic and treatment options available nowadays. Next. Next, this we have already covered. Next. Next. So initial couple slides, I just want to re-emphasize what is a normal majority of the patterns which we see in our practice. Next slide, please. When you see clear cell morphology, next, in couple of slides, yeah, Aman, you can change it a little faster. Okay, I can tell you when to stop. Yeah, next, please. Next. So this is all classical garden variety, clear cell, chromophobe. They are all, you've seen them. You know how to pick them up. Next. So if you have clear cells, you will have differential of clear cell RCC, chromophobe RCC. Differential will be on the basis of nuclear features and vasculature and cell lines. Next. If you have papillae with clear cell, differential will change. Next. Aman, you can keep on changing. I'll tell you where to stop. Okay. So this is papillae with clear cells, and here differential will be, you can see papillae in clear cells also. You can see in translocation associated RCCs. Okay, next. Yeah, and also you can see them in papillary RCCs. So this is again the classical thing, and you have, what are the IHCs for clear cell? You have to do CA9. For clear cell papillary, you have to do CK7, and then for translocations, you have to check for TFP3. Papillary RCC will be positive for AMACR. Yeah, next, this is clear cell papillary. We'll come to this later when we talk about 2022. Next. This is MITF associated, TFE3. We'll also talk about it little later. Next. Next. Yeah, next, please. So differential of papillary tumors, so till now we learned what are the clear cell tumors, main differentials, then clear cell with papillary morphology differentials, then differential of papillary tumors without clear cells. You can have papillary carcinoma, papillary adenoma, mucinotubular spindle cell carcinoma, and metanophic adenomas. They are all well-known entities. They have been there in last two WHOs, and they are well known and well characterized by their classical RCCs. Next, please. Next. Next, 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 next. Yeah. So oncocytic, initially for majority of this thing, the oncocytic is known as either oncocytoma or chromophobe RCC. This particular category of RCCs have undergone enormous expansion in last decade or so, and many of new entities have come up, which initially we probably were clubbed into chromophobe and oncocytomas, and we'll come to that. Next slide, please. Next. Next. So these are, yeah, go back to the previous slide. So these are the couple of new entities which have come up in the differential of oncocytic tumors. You must have heard about low grade oncocytic tumor LOT, then eosinophilic solid cystic RCC ASC, then SDH deficient RCC. These are all oncocytic tumors which do not show primarily clear cells, do not show papillary morphology. They are usually arranged in sheets, have pinkish cytoplasm of the cells with little bit of cytoplasmic coagulation in some of the entities, and some subtle nuclear changes or subtle morphological changes to differentiate from each of them. So they now all come under the spectrum of oncocytic tumors of kidney. And when you see a pink tumor in kidney which is not clear, not papillary, you should keep all these differentials in mind before labeling it either as chromophobe or oncocytoma. Next. Yeah, this we've already done. So this is to re-emphasize, in 2016, we had clear cell papillary RCC. We had HLRCC, associated RCC. We'll come to these entities because they have been a little tweaked in 2022. So I'll come in detail to these entities. This acquired cystic disease associated RCC was also updated in 2016. Then SDH deficient RCC was included in 2016, and tubulocystic was included in 2016. All these entities have characteristic morphological features and can be picked up either by morphology or associated characteristic IHC. Next. Next slide, please. Yeah, and this is the immunohistochemical profile milieu which you should have when you are dealing with a huge volume of renal cell tumors, because nowadays you need to have certain IHC markers before you diagnose any particular type of RCC. And if you are in a setting where you see quite a good number of renal resections or renal tumors, whether in pediatric or adult population, you should have all this in your armamentarium to pick up all these differentials. Next. Next, please. So now we'll come to the actual content. This was just a preview that how the classification has expanded from the initial only clear cell and chromophobe and papillary to a couple of new entities in 2016, and the expansion of oncocytic tumors of kidney from onco to chromophobe to new entities. So today's talk, I'll just focus on what has been recently added in 2022. And there's been a little change in the nomenclature of some of the entities, which I think, since we live in a contemporary setting, you should be signing out these kind of tumors. So you should know what is the exact terminology to write in these kind of reports. Next slide, please. Yeah, so I'll be going by this particular flow. So I'll be telling you what are the most important changes in the WHO 22 classification of kidney tumors, and we'll be following each of these entities in next 20 or 30 minutes which we have, and I'll be focusing on how to pick up these entities and how to report these entities, what are the morphological subtleties or morphological nuances which you need to know to pick them up, and also how to pick them up with the help of typical IHC or whatever molecular changes are there. Okay, so coming to first papillary renal cell carcinoma. Next slide, please. what changes, what is the change in the new WHO? So as they say, if you know your previous listing, kidney tumor. So initially for many years when we were trained, we were told that papillary RCC is classified into type 1 and 2, with type 1 you having, indolent morphology and indolent behavior, while type 2 will have nuclear stratification and, aggressive behavior. For clinicians, it's still the type 1 and 2, but since, as I said, the molecular underpinnings have enormously expanded, and there are lots of molecular changes in last couple of 2 decades when with the genomic testing and everything coming into picture. So type 2 type of papillary has been actually diversified into many different type of newer RCCs, like FH deficient RCC is probably a shootout from your type 2 type papillary RCC, and many others have been now again a shootout from your type 2 RCC. So that's why this time WHO said that no, we are not going to sub-classify into type 1 and 2. So when this time when you encounter a papillary RCC, even if it looks like type 2 or type 1, it is a recommendation, best practice recommendation, that you should not type into type 1 and 2. So just write papillary RCC if you're not able to fit into any other further molecular subtype. So the first thing, the point to remember or take home message from WHO 2022 regarding papillary RCCs, subclassification of to type 1 and type 2 is no longer recommended. And how you pick up papillary RCC by its papillae and tubular architecture. Okay, if you can have histiocytes, which we initially used to say that is more commonly seen in type 1 type of RCC. And these kind of RCCs have diffuse immunohistochemical staining for a marker and also for CK7. So this much you remember: positivity for a marker, CK7, papillary morphology, homohistiocytes, just type it as papillary RCC. If you feel that it's looking like type 2, you should rule out FH deficient RCC and do FH-IHC and say that FH is retained before giving it as papillary RCC. So that is a recommendation. Next slide, please. So apart from that, new 4 types have been added in the papillary RCC. These are rare types. They are seen very less commonly, only few case reports of each of these entities, but still you should be aware and you should be able to pick up if you've seen it. So our first type is biphasic papillary RCC. So how does this look like? Biphasic name itself says that it has dual population. So it will have this alveolar squamoid type of nest, glomerular architecture surrounded by these small cells. Okay, so this is how it looks like. And second type is Warthin type papillary RCC, which, as the name describes, contains eosinophilic tumor cells with admixed lymphocytes. This exactly looks like a Warthin tumor of salivary glands. Okay, so Warthin type of papillary RCC, biphasic papillary RCC, these are rare, but people do see. I have seen people from peripheral colleges presenting case reports of these kind of RCC, especially biphasic. So if you know, your eyes will pick up these kind of papillary RCC. Next slide. So third type they say is solid papillary. No, previous slide, please. Previous. Go back. Yeah. So the third type of papillary RCC is your solid papillary RCC, which probably you must have seen. It looks very tubular, looks like your adenoma, and it can be really difficult to pick up. And third type is, which is very important again, is papillary renal neoplasm with reverse polarity. So what they say is it is essentially the one type which we initially used to look like, oncocytic type of papillary RCC. So you will have papillae, you will have this papillae lined by oncocytic cytoplasm, and reverse polarity means the nuclei will be lined away from your basement membrane abluminal. So these are the 4 types which new WHO tells that these are the 4 types, rare types. So broadly, when you see papillary RCC, you will still, be fitting it into classical papillary RCC only, and you should not label it as 1 and 2. You should do FH staining just to rule out that it's not FH deficient in case it is looking like kind of type 2 papillary morphology. And if you see these kind of subtle morphological hints towards these neotypes, you can easily diagnose and put them in your report. So Warthin type, biphasic alveolar squamoid, solid papillary, and papillary renal neoplasm with reverse polarity. This one is also has molecular underpinnings that they have KRAS mutations. So this is how you pick them up. Okay, so this was all about the update about the papillary RCCs in new WHO. Okay, next slide, please. Next, yeah. So coming to clear cell papillary renal tumor. So the take home message here is that since these tumors were this entity was first entered in 2016, and then it was labeled as clear cell papillary RCC. But over a couple of years, it's been observed that this particular tumor is very indolent and doesn't behave aggressively, doesn't metastasize and all that. So the terminology has been changed from clear cell renal RCC, clear cell papillary renal cell RCC to clear cell papillary renal cell tumor. Okay. So that is the second important change which has happened. So this particular entity, they have changed the name from carcinoma to tumor. Next slide, please. Next. How do we pick up this entity? So, as the name says, this particular tumor will have both clear cells and papillae. But it's not that the two areas will be separate. So this is what my trainees also do this mistake. In some renal tumors, they see papillae in one focus and they see clear cell in one focus, and they say, ma'am, is it clear cell papillary RCC? No, it's not clear cell papillary RCC. So they are not showing separate areas of clear cell and papillary. So what is there in the morphology is you will have tubules, papillae, short papillae, not as classical papillae as you see in your classical papillary, tubules, papillae, and nests and cysts of varying proportion, which are lined by low columnar cuboidal cells. So here the ISUP grading is always grade 1 or 2, not beyond than that. Okay, so low nuclear grade papillae and tubules, which are lined by clear cells, and nuclei are oriented towards the luminal aspect of tubules and papillae. So abluminal nuclei. So this is how this particular entity is picked up. It's very important to pick up and not label these as clear cell RCC or papillary RCC because it has got very good prognosis. They're usually small, well circumscribed, well encapsulated, almost more than 95% PT1. And if you are actually giving this diagnosis, that's actually good for the patient because they will almost have negligible chance of having any kind of metastasis or any kind of adverse clinical behavior with this kind of RCC. Clear? So this is about the clear cell papillary renal cell tumor. It is not carcinoma. It is indolent. It is picked up on morphology and confirmed on IHC. Go to the next slide. What is the classical IHC? I'll tell you. Just remember this picture. Clear cells, tubules, and this abluminal nuclei. Okay, go to the next slide, please. Next slide. Yeah. So what is the classical picture? Classical picture is diffuse CK7 staining and cup-like CA9 staining. Okay. So CK7 has to be diffuse to call it clear cell papillary. If you're not seeing CK7 positivity, which is diffuse and strong, you should refrain yourself from calling it as clear cell papillary tumor. Okay, and CA9 should not be diffuse. It should be just cup-like or on the tips of your lining of the cells. Okay, so diffuse, strong, membranous, box-like positivity is seen in clear cell RCC, whereas cup-like is seen in your clear cell papillary renal cell tumor. Okay, so clear about this. And yes, one thing you have to importantly remember is clear cell and papillae are not separate areas in this tumor. So it is basically papillae which are lined by clear cell, have abluminal nuclei, show diffuse CK7 positivity and cup-like CA9 positivity. If you see this, you are more than 100% sure that you are dealing with this clear cell papillary renal cell tumor. Next slide, please. So this was the second entity. So I think I've made you aware about what is updated in papillary RCC and what is new entity clear cell papillary renal cell tumor. Now coming to the third important, very important entity, which is TFE3 rearranged and TFE-B altered RCCs. Now, initially in 2016, you must have heard about translocation associated RCC. This was clubbed as MIT family of RCC, microphthalmia associated translocation family of RCC. Now, since this entity has expanded, they have removed this term MITF family of RCC. Rather than that, they have subclassified into TFE3 rearranged and TFE-B altered RCCs. Okay. Next slide. So in this particular entity, we have three types of tumors. The most common is TFE3 range, which I'm sure most of you have seen, or if not seen, probably have read about it. It's quite known now in public domain. So TFE3 is the most common, TFE3 rearranged RCC. What is the molecular characteristic molecular change here? Pardon me. So classical molecular change here is you have fusions of the gene involving TFE3 gene with different partner genes. And most common partners are PRCC, ASPS-CR1, and SFPQ. And apart from that, you can have other rare partners. So basically, it's translocation or gene fusion involving the TFE3 gene. And how do we pick it up? Next. Next slide. How do we pick up? So they say WHO has now listed for each type of RCC essential criteria, desirable criteria. So you can only call a particular type of RCC as this type of RCC if that RCC is meeting the essential criteria. So for labeling this type of RCC, morphologically, apart from the morphological hint which I'm going to tell you, you have to have strong nuclear positivity of TFE3. So when I'm talking about TFE3, it has to be strong and diffuse. Okay, with clean background, nothing in the background. So a wispy, a wispy brownish kind of discoloration with the background and not crisp and not nuclear kind of TFE, which is very common because it's not a good IHC to standardize, should not be called as positive. So that is kind of false positive, and you should not label with these kind of IHCs as TFE3 rearranged RCCs. Okay? And but the apart ISC they say is not very specific and it's not a best practice recommendation. The best practice recommendation is go for TFE3 probes. So there's a break apart probe, fish probe, which can pick up this TFE3 translocation, or you can go for RNA sequencing to pick up TFE3 fusion. So fish is pretty common, and now most of the labs are able to do it. So to confirm this kind of RCCs, you should be doing fish. Okay. And what is the morphological hint that it is a TFE3 rearranged RCC? The morphological hint is that you have papillae lined by clear cells with abundant cytoplasm, some Momo bodies. So this is the morphology. Next slide, please. Next. So you will see these broad papillae. No, previous slide, please. Previous. So broad papillae. These broad papillae are lined by cells with abundant clear cytoplasm, okay, and Samoma bodies. Samoma bodies are almost always seen in these kind of RCCs, and this is a TFE3 positivity, strong TFE3 positivity. If TFE3 is not there, then these kind of tumors are usually cytokeratin shy. They will be pan-CK negative, and they will show positivity for the cathepsin K. So that's a strong hint. So that's a strong hint that you can, if you don't have TFE3, so first thing to pick up, if you are feeling probably this we are dealing with TFE3 and RCCs, you can go for pancytokeratin, which is usually negative in these kind of RCCs. Go for cathepsin K. In majority, more than 50% of these kind of RCCs, translocation RCCs, you will have cathepsin K positivity. Or if you don't have cathepsin K, just go for melanocytic markers, HMB45 and Melan. In close to 50% of cases, you will see some kind of positivity because they are again a downstream pathway same of this kind of RCCs. Okay, so cytokeratin negative or shy, cathepsin K positive, Melan and HMB positive in close to 50% cases gives you a hint when you are morphologically suspecting TFE3 range RCCs, and you can confirm it with TFE3 IHC if it is well standardized, or the best practice recommendation is go for a TFE3 break apart fish. It's very important because this kind of RCCs have kind of aggressive behavior as clear cell RCC, and they're mostly seen in pediatric population. Is important to differentiate from classical clear cell RCCs. Next slide, please. So another category which they have now added apart from TFE3 is TFE-B range. So this was also there in 2016, but now we have two different types of TFE-B associated RCC. One is TFE-B rearranged and the other is TFE-B amplified. So both have different morphologies. TFE-B rearranged is more common, but these kind are very less common as compared to your TFE3. So they are not as commonly encountered. Even in our heavy surgical practice, we see rarely these kind of RCCs. So what is the molecular underpinning here? You have TFE-B transcription factor having translocation with 611, resulting in MALAT1 TFE-B fusion. So these are previously called as 611 translocation RCC. TFE3 was called as TFE3 as translocation RCC, and this was called as 611 translocation RCC. This is now called as TFE-B rearranged RCC. As I told you, they are less common than TFE3. And go to the next classical morphology is you have this biphasic population. You have these clear cells arranged in tubules and nests, and then in center you have these small cells, nests of small cells with pink eosinophilic, basophilic basement material in between. So this is the classical morphology biphasic. You can pick up if you know that they look like this, and this can be easily confirmed by again TFEB ISC, which is more specific than TFE3. Next slide, please. Next, yeah. So again, you can do either TFEB IHC. If you don't have IHC, straight away go for the break apart fish for TFEB, which will show 611 fusion. And also, if you still want to confirm, you can go by TFE3 gene fusion by RNA sequencing. Okay, so they have better prognosis than TFE3 in RCC. You should know that this is another type of translocation RCC, and this is the biphasic morphology. And we have IHC and fish to pick up these kind of IHCs, okay, these kind of RCCs. Next slide. Next slide, yeah. So again, to highlight the biphasic morphology, you have these papillae or alveolar spaces lined by clear cells, and in between you have these small cells which are larger epithelioid cells in the periphery, small cells which are clustered around this hyaline basement membrane material in the center. So this is the look of a TFEB rearranged RCC. Next. So another new entity which they have now added in this translocation associated RCCs, one is TFE3 translocation, then TFEB rearrangement is TFEB amplified RCC. So this has different molecular this thing. Here you have amplification of peptide arm of chromosome 6, which harbors TFEB gene. And here there is no translocation, it is just the amplification resulting in TFEB overexpression and downstream effects. It is much less common. It is usually seen in older patients as compared to your TFE3 and TFEB, which is seen in younger population. And again, you can pick up this by TFE amplification on a fish probe, or you can do a TFEB gene fusion on a RNA sequencing. The idea is you should know that there are the 3 different type of translocation associated RCC which have been added in new WHO. TFE3, you all have already known about it. So the 2 new entities are TFEB rearranged and TFEB amplified. Both are very rare, and both can be picked up by classical break apart fish probes and their morphology. For TFEB, the morphology is variable. Go to the next slide. Next slide. So here for the TFE rearranged, I told you biphasic population with alveolar spaces in between you have small cells. Here it can be variable morphology. You can have solid nested appearance. You can have tubulopapillae architecture. It's very difficult to pick up these kind of RCCs. Okay, so only hint is that they will have tubulopapillae architecture, are high grade and not fitting into your classical clear cell or papillary type of RCC, and all other differentials you ruled out. Then only you pick up these kind of TFEB amplified RCCs. They are so less in number that as of now the classical morphology and the behavior is not exactly known. Okay, but you should know that these are the 3 types. Next, please. So we've covered papillary RCC, the updates. We've covered the clear cell papillary, TFE3 range and altered RCC. Now quickly we'll cover all these entities in next 15-20 minutes before we go to the bladder talk. So I'll continue with this because these are very important entities, and I think we can cover up in 10-15 minutes and before we go to the bladder, which will be easily covered in 30 minutes. So next slide, please. We now learn about FH deficient RCC. The important thing to remember is that this is now has been initially in 2016, this was labeled as HLRCC associated RCC because they thought that probably all cases of these kind of RCCs are syndromic and have germline mutations, and hence it was labeled as hereditary leiomyomatosis associated RCC. But as the evidence accumulated, as people started picking up these kind of RCCs, so it was known that it's not always germline mutations. They can be seen in somatic settings also with classical morphological features and IHC. And hence in 2022, the change is that now they are not labeled as HLRCC, they are labeled as fumarate heritase deficient RCC, and only if there's an evidence of germline mutation, we call it as HLR RCC associated RCC. I hope that's clear. That's very important. And it's one ISC. If you want to remember 1 or 2 RCCs from this talk, I think we should remember about this translocation associated RCCs and FH deficient RCC, because it has not only for implications for the patient but also for the family in case it is a syndromic or has germline mutations. So this is where I think pathologists will play a very important role in picking up this kind of RCCs, going for molecular testing, and in case it is germline, going for a genetic counseling for the family. So this is one RCC I think should everybody who's listening to this talk should be aware that this is how it looks like, this is how it should be picked up. So what exactly is fumarate hydratase deficient RCC? Fumarate hydratase, you know, is a part of Krebs cycle, enzyme in Krebs cycle. And what are the essential criteria here to pick up this kind of RCC? The WHO says that you have to have a demonstration of either germline or somatic mutation of FH or immunohistochemical evidence of FH deficiency in the form of FH loss and 2SC, which is 2-succinylcysteine expression. Only then you should label it any kind of RCC as fumarate hydratase deficient RCC. Okay. So before going for this kind of, ISC evaluation and molecular testing, what are the molecular hints? How do we pick up this kind of RCC? The first important thing you have to remember regarding FH deficient is it has multiple admixed architectural patterns. Okay, so in some areas you will see these kind of papillae, some areas you will see these cystic spaces, some areas you will see these kind of solid sheets. But in almost all of the cases, one thing which is common is the nuclei are very high grade, isograde 3 to 4 with presence of macronuclei. You will see cherry-like nucleoli, just like you see in your melanomas or your, hepatocellular carcinomas. So those kind of eosinophilic cherry-like nucleoli, they are usually seen, but they are not cyanoquinone. It's not that they are the most specific thing, but in more than 90% of the cases, you see these kind of cherry-red nucleoli along with papillary morphology and cystic morphology, and nuclei are high grade. So essentially, what you see in type 2 type of papillary RCC, the previously designated type 2 type of papillary RCC with prominent cherry red like nucleoli. So that's a strong hint that probably you're dealing with a FH deficient RCC. They are often aggressive, and in case they are germline associated or also in syndromic, they are associated with history of uterine leiomyomas and cutaneous leiomyomas. So if you have a young female, with coming in 20s and 30s with a kidney tumor, and that tumor is showing this kind of morphology with this kind of nuclei, there's very high chance that probably that lady might be harboring this FH deficient RCC, and go and check for uterine leiomyomas and cutaneous leiomyomas also. Next slide, please. Next. So again, to re-emphasize, the important thing is that there is a variable morphology. You may have papillae, you may have tuberocystic architecture, sieve-like cystic architecture, and macronucleoli. Next. This I've already highlighted. Next. Next slide. Yeah, how we pick up? The easiest is you have FH and 2SC IAC. So FH deficiency with positive internal control in endothelial cells. So loss of FH in presence of FH positivity in internal control and overexpression of 2-succinylcysteine, 2SC, both nuclear and cytoplasmic, is actually kind of diagnostic. If you have this IHC or you have a referral lab where this IHC is available and you think that probably this could be differential, it is worth giving a try to check for it, considering the aggressive nature of this RCC, considering the syndromic associations this type of RCC has with germline mutations. Okay, next slide, please. So this was regarding the FH deficient RCC. So again, to re-emphasize, it is the preferred name since we have both germline and sporadic settings in which these kind of RCCs can occur. Variable morphology with prominent nucleoli, papillae, and FH loss and 2SC overexpression is more than enough to diagnose this as FH deficient RCC. Now coming to the next RCC, which has been changed in 2022, that is called SMARC-B1 or INN deficient renal medullary carcinoma. So this name has been changed from the only term which is called medullary carcinoma. So medullary carcinoma is now called SMARC-B1 deficient renal medullary carcinoma. Next slide, please. So again, SMARC-B1 deficient renal medullary carcinoma is kind of, renaming of your medullary carcinoma. So this is a high-grade medullary carcinoma associated with SMARCB1 deficiency. And as you remember your previous core teachings, the medullary carcinoma is usually, this type of medullary carcinoma is associated with your sickle cell trait and usually seen in medulla, but can also be located in cortex. And what happens is that because of the hypoxic condition in the medulla and microvascular occlusion because of the sickle cells, there are double-stranded breaks leading to inactivation of SMARCB1. So hence, this is SMARCB1 deficient renal medullary carcinoma. So you see in endothelial cells, there is the presence of SMARCB1, and then in tumor cells, it's deficient. So how do we diagnose it? It is just like your classical medullary carcinoma, which is like infiltrating high-grade adenocarcinoma, plus you have evidence of hemoglobinopathy or sickle cell disease. Just like FH deficient, they are also aggressive tumors, hence you should know how to pick them up. They have poor prognosis, and about more than 90% of the cases will show metastasis to lymph nodes and other sites. And median survival is usually, I haven't seen any patient, crossing 1 year or 1.5 years. They're usually less than 1 year. So it's very important you pick them up. So the morphological hints are just like the high-grade adenocarcinomas you see somewhere in your breast or in, in colon. They are very aggressive kind of adenocarcinoma with areas of sclerosis, inflammation, and you can also check for the sickle cells in blood vessels or surrounding RBC, sickle cell trait. Next slide. Next slide, please. So, yeah. Is this meeting going to stop in another 1.5 minutes, Aman? Is it like that? Or we can continue? Are you around? Aman? Hello?
Continue.
Hello. So because I want to continue with this presentation.
Continue, ma'am.
All right. Yeah, because I'll finish this and then go to the bladder one. We have time till 1 o'clock, and I can easily cover up both the topics. Okay. So just to continue with SMARC deficient, B1 deficient RMC. So it has infiltrating pores, nests, microcysts and sheaths and tubules, and desmoplastic reaction around these cells. And you will see sickle cell RBCs in your blood vessels. Next slide, please. Next, yeah. How we pick up? We pick up by your loss of INI1 or SMARCB1, which is a ISE available in most of the labs these days. And only thing is you should have positive internal control and C for SMARCB1 deficiency. Next. Next slide. So another important, coming to the few of the new entities which have come up. One is this eosinophilic solid cystic RCC. This is a new entity in 2022, and it's very easy to pick up if you know it. Go to the next slide, please. Yeah. So as it's the name is obvious. So you have eosinophilic solid and cystic type of RCC, which means it's a pink tumor. It will have both solid and cystic areas. Okay. So solid and cystic architecture, eosinophilic cytoplasm. The eosinophilic cytoplasm is granular with basophilic cytoplasmic stippling. So if you go on a high power, you will see probably these cells look like as if you have some kind of leishmania or LD bodies in the cytoplasm. So that kind of basophilic stippling, and both diffuse and both solid and cystic architecture and eosinophilic cytoplasm, that is the defining feature on morphology of SCRCC. They are usually associated with mutations in TSC1 and TSC2 and are associated with tubular sclerosis and upregulation of mTOR pathway. Next slide. So essential criteria is you should have voluminous eosinophilic cytoplasm with basophilic stippling. Okay, so this is essential criteria. And another thing which is important to remember is these kind of tumors till now in published literature, almost all of these cases have shown CK20 immunoreactivity or positivity. So the take-home message from here is if you are seeing an oncocytic tumor in kidney, which is not classical chromophobe or oncocytoma, you should always put in CK20 as differential and go for the morphological hints whether there's a voluminous eosinophilic cytoplasm and basophilic stippling, and there is CK20 positivity, which may range from focal to very diffuse. So we have seen a couple of cases. In some of these cases, it was classical diffuse CK20 positivity, and in some it was focal positivity. So this is how you pick it up. It's again a tumor which has got very good prognosis, and initially it was said that it is usually seen in females. Now we've also, as the evidence is accumulated, we've seen them in happening in males also. Next slide, please. Next slide. Yeah, so you can have cystic areas, you can have solid areas, you can have voluminous eosinophilic cytoplasm, basophilic stippling. Next slide. Next slide, please. And CK20 positivity, which may range from diffuse to focal. Okay, so if you see this kind of morphology with classical CK20 ISC, straight away you can write the report as features suggestive or features consistent with eosinophilic solid cystic RCC. As of now, mTOR or TSC mutations are not required for the diagnosis. They are not molecularly defined, but only morphology and CK20 immunohistochemistry is sufficient to give a diagnosis. Next slide. Picking them is important because they behave much better than your other oncocytic tumors, especially Kumoko RCCs and all. Okay. So another important entity is anaplastic lymphoma kinase rearranged RCC or ALK rearranged RCC. This is again a new entity and this come under the molecularly defined renal cell carcinomas. Next slide. So as the name suggests, these kind of RCCs, they have rearrangement of ALK genes. So there are mutations involving the anaplastic lymphoma kinase gene on chromosome 2. And it's important to pick up these kind of RCCs, and you know why? Because they are also sometimes seen in pediatric population, and just like your lung tumors and lymphomas and all that, it can be picked up. You don't need a fish probe or something to pick up. They can be picked up by specific ALK ISC with the same clone which is used in lung and this thing, and they have different prognosis as compared to the other RCCs. So as of now, very less cases have been reported. Till the cases which have been reported, they say they are small tumors, organ confined. Only 50 to has been written in 2022. I think only 50 to 100 published cases will be there in the published literature, and they can be seen in both children and adults. And most common fusion partner is VCL gene. And morphology is quite variable. They are one of the most difficult RCCs to pick up. There's no, just like your FH deficient RCC, here also you can have a wide variation of morphology. You can have papillae, you can have, sheets, you can have inflammation. Next slide, please. I'll tell you a few soft hints to pick up this RCC. In our institute also, it is usually picked up in the last because it has got such a, different morphology, and when we rule out or rule in other RCCs, and then probably sometimes we do the ALK and it gets picked up. So this is how it is usually picked up. So, but it's important because it's molecular defined, it is amenable to treatment with ALK inhibitors, okay, and it has got different prognosis than rest of the RCCs. So essential criteria is documentation of ALK rearrangement by FISH or sequencing. This is essential criteria told by WHO, and but you can also pick them up with specific IHC first in screening and then go for the rearrangement pick up by the FISH. So this is how usually we diagnose this kind of ALK RCCs. Okay, they are also associated with sickle cell trait. And as of now, we don't know the prognosis because there are very less number of cases. It's good that if you see these kind of RCCs, you should do ALK in your differential. The take-home point message from this particular RCC is that if you see a RCC in which you see variable morphologies, somewhere papillae, somewhere sheath, somewhere mucinous background, wispy, myxoid background, and inflammation, you should put ALK IHC as differential to pick up these kind of RCCs. Next slide. Next. No, the previous slide. Yeah, this one. So just, no, previous one, please. Previous. Yeah. So how do we pick up on morphology? So they're well circumscribed. They may have inflammation. Cells are usually polygonal with abundant eosinophilic cytoplasm, sickle cells. And as I told you, just like FS deficient, they show tumor heterogeneity, papillary and cubiform architecture. And what I find in my practice is a very important or a very soft point, which I've seen in almost all the cases which I picked up, is myxoid background or mucinous stroma. So pay attention to this. If you see a RCC which has got variable morphology, is probably in pediatric population and has got very strong mucinous stroma or myxoid background, then you should, I think, and is high grade, you should put in ALK, IHC differential, and then confirm it by break apart fish. Okay, so this is how you pick up your ALK RCCs. Next slide. Next. So this is how ALK. This is a little soft picture. You can see a good positivity of ALK in couple of ALK associated rearranged RCCs, and this is your break apart fish. Next. Next. So these are the important entities which have come up, and quickly I'll go through the three more entities which have come up in WHO, new WHO 2022. One is ELOC mutated RCC, low grade tumor, and EVT. Out of this, I think there are high chances that you will probably see lot. ELOC and EVT are very less common and still can be picked up. Go to the next slide. So ELOC, formerly TCB1 mutated RCC, and what is the defining criteria? You will have mutations in the ELOC, which is TCB-EB1 gene on chromosome 8. And as of now, I think it's been less than 50 cases reported. There are only few good studies on these kind of tumors, and most of them probably have been misdiagnosed as clear cell RCC because they have not been picked up. So essential, what is the clue to pick this up? Clue is that you will have a clear cell RCC with fibromyomatostroma. So these were also previously known as clear cell RCC with fibromyomatostomas, which have now got molecular alteration and have been labeled as ELOC or TCB1 mutated RCCs. Next slide. Next. Next, please. Yeah. So if you see this picture, I'm sure you must have encountered these kind of RCCs in your practice if you have get a lot of renal tumors in the surgical pathology practice. So in most of, including us, probably before this entity was coined, probably these would have been diagnosed and picked up as clear cell RCCs or with clear cell RCCs with prominent papillary pattern. So nowadays they say that if you see these kind of tumors with clear cells and papillae and predominant fibromyomatostroma, you should go and check for ELOC mutations. Okay, next slide. And probably they are now labeled, probably they'll come up as ELOC mutated RCCs. Next slide. Yes, again, pay attention to this picture. So what you see is branching, enfolding tubules and papillae with voluminous clear cytoplasm and prominent cell borders. Probably this will have differential of your translocation associated RCC, and if indolent nuclei, clear cell papillary RCC. So all these differential will come into this. After ruling out those entities, if you still feel that it is not fitting into classical, clear cell RCC morphology, go for testing for ELOC mutations. Before that, what are the IHC clues to this? Next slide, please. So these type of RCCs are positive for CK7, patchy to diffuse, and as compared to clear cell RCCs, they have CA9 positivity, which is complete membranous. Okay, so apart from complete membranous CA9 positivity, they will also have CK7 patchy to diffuse. CD10 is very sparse. So essentially, the previously seen clear cell RCCs with prominent papillae and diffuse and fibromyomatostroma have now been clubbed into this type of RCC, and it's been seen that these kind of RCCs though show mutations of ELOC or TCB1, and hence it's been labeled as molecularly defined type of RCC. Next slide. Coming to the low-grade oncocytic tumor. Next slide, please. This is, I think, probably you must have seen, and this I think, apart from FH deficient and TFE3, this is the third most common tumor probably you're going to encounter in your practice. They this lot or low grade oncocytic tumor is tumor which is classified with the other oncocytic tumors of the kidney. As I said in the beginning of the talk, that now we have expanded the spectrum of oncocytic RCCs. They're usually low grade, picked up incidentally, may be associated with TSC mutations. Next slide. May be associated with TSC mutations and tuberous sclerosis. And how do they pick, we pick them up? They will, on low power, essentially look like your oncocytomas, but they will not fulfill all the criteria of oncocytoma or chromosome RCC. So what will you see? You will see these pink cells arranged in sheets, but lacking the nuclear wrinkling of chromosome or clear cytoplasm of chromosome. Next slide, please. Solid growth of eosinophilic oncocytic cells, low-grade nuclei lacking the prominent nucleoli and nuclear regularity, okay, and diffuse immunopositivity for CK7. For diagnosing LOT, you have to have a diffuse immunopositivity for CK7 and negativity for CD117. Next slide. So you will have compact and nested growth pattern, eosinophilic round nuclei, and diffuse CK7 positivity. Only if you have diffuse CK7 positivity along with CD117 diffuse negativity, only then you should label these tumors as low-grade oncocytic tumor. Otherwise, most likely, previously before this was known, probably they were all diagnosed as oncocytoma when ISC was not done. But nowadays, they say for oncocytoma, it shows positivity for CK7 focal, not as diffuse, and also will be CD117 negative. Next slide, please. So they have to be differentiated from your oncocytomas. Next slide. Next, please. Yeah. So strong and diffuse CK7 expression and immunonegativity for CD117 and CK20N, of course, by maintain. They have been shown also to show GATA3 positivity. Okay. So that's additional. Sometimes you are not sure whether you're dealing with a oncocytoma or LOT, and you have some, not very characteristic ISC. GATA3 nowadays, recent literature says that many of these LOT tumors show GATA3 positivity. Next slide. So coming to the last entity of the new WHO RCCs in 2022 is EVT or eosinophilic vacuolated tumor. Again, a very important tumor. Next slide. So this is a high-grade oncocytic tumor. Again, oncocytic, but as compared to LOT or oncocytoma, these are high-grade. Means you will have nuclear features which are amounting to grade 3 or 4. You will have anaplasia, not anaplasia, but prominent nucleoli and big nuclei. Okay, so basically high-grade nuclear features and coupled with cytoplasmic vacuolation. Okay, so single vacuole in the cell and high-grade nuclei. So this is called eosinophilic vacuolated tumor. The term itself vacuolated. They will show vacuolation. Eosinophilic cytoplasm coupled with high-grade nuclei. They were initially called as high-grade oncocytic tumor. So they were LOT and HOT, but HOT term has not been included. Rather, it's been renamed as eosinophilic vacuolated tumor. Next slide. Difference from LOT is that they will have there you will see here you will see vacuolations and high-grade nuclear features. Okay, but still very less literature to know about the behavior and all that. You will have frequent cytoplasmic vacuoles and prominent nucleoli. Next slide. This I've already highlighted. It can be picked up by positivity for cathepsin K. All right. Next slide. Just to highlight, they are positive for cathepsin K, CD117, and focally for CD10. So if you see a tumor which is looking eosinophilic but is also showing cytoplasmic vacuolation and high-grade nuclear features and prominent blood vessels, probably we are dealing with the eosinophilic vacuolated tumor, and you can confirm it with cathepsin K and CD117 IHC, which will show diffuse positivity. Okay, so this is how you pick it up. Next slide. So this is to summarize again that these were all the new entities which have been added in WHO. Some of them have been renamed. Some of them there's a change in the criteria of diagnosing. So idea of this talk was to update about what is latest happening in renal cell tumors. And if you have all the IHCs, even if you don't have IHCs, you know how to pick them on morphology. You can always go to a referral lab and check for these IHCs because many of these entities are now molecularly defined. Many of these will have different prognosis. Many of them will have, the molecular ones especially, will have targeted treatments available. So it's now the era from clubbing everything into clear cell and papillary and chromophobe or oncocytoma is moved on to close to more than 20 RCCs. And I hope I have done justice to the newer types. And I'm open to questions if you want to take right now, or we can move to the next talk and take QA and then end of the session. I'm open to either of this thing. So, Aman, what do you suggest? We should do QA at the end, or we should? I can answer questions regarding RCCs right now for 2 minutes, and then we move quickly to the bladder update, which I'll finish in 30. All right, I think audience is already there, so we'll go to the next topic, which is update in the WHO 2022 bladder tumors. And again, the first update is that now WHO says that all urothelial tumors, whether they're in urethra or in pelvis or in bladder, they have similar, underpinnings, molecular underpinnings, and anything which is happening in bladder urothelial tumor is also applied to urothelial tumors which are seen elsewhere. That is includes urethra, pelvis, and ureters. All right, so that's the first update. So when we talk about the carcinoma bladder, as compared to RCCs, is not that glamorous, but still it is one of the most evolving fields in geopathology. A lot has happened with the molecular classification. A lot of new therapies have been tried and tested in carcinoma bladder, and we're going to briefly touch upon what is happening. So, as you know, regarding the bladder, more than 90% of bladder tumors are urothelial carcinomas. And if you talk about the clinician point of view, they are classified as non-muscle invasive and muscle invasive. This is what matters to the clinician still. And more than 90-80% are non-muscle invasive. They are recurrent, but they have less mortality, while muscle invasive are 20% and are responsible for majority of the bladder cancer deaths. So again, the same thing. And if you go to the classification, for many years, the urothelial carcinoma was classified into TCC grade 1 and 2, and this 3-tier classification is still followed in the Europe. However, US and other countries, including India, here we follow 2-tier system of high grade and low grade, considering that grade 2 TCC was kind of probably being misused as waste basket category. So this is how it is. So in 1992, ISUP came with this 4-tier classification of papilloma, pulmonum, low grade and high grade, and essentially this is what WHO is also endorsing, and this is what majority of the pathologists use in US, India, Asia, and everywhere, excluding Europe, which they still use, in which they still use 3-tier. Okay. So yeah. 2016 WHO has continued to recommend the 1992 4-tier classification of papilloma, pulmonum, low grade and high grade. This was 2016. There were a couple of entities which were added or renamed. We're now going to do in detail in that on 2016. So let's straight away go to 2022, what is happening here. So just to reinforce that we still use the 4 major categories of bladder tumor, that is papilloma, pulmonum, low grade and high grade. And there are some variants or subtypes which have been changed. So one important thing which you have to remember is in 2016 they used to say histological variant, but now they say that term variant is used only when you have a genotypic abnormality along with that, when you have documentation of certain mutation or genotypic alteration. If you're seeing only morphology, you should label it as histological subtype. So what I mean to say is if you're seeing a micropapillary morphology on HE and you want to write in bladder carcinoma high grade urothelial with micropapillary subtype, not micropapillary variant, because you have not done mutational analysis or molecular investigation. Okay, so variant is used only when you have a documented genotypic alteration, while if you're seeing only morphology, use the term subtype. Okay, so microcystic now included. You also have large nested and tubular, plasmacytoid, and clear cell and glycogen rich. These are the new entities which were there in 2016 and have been retained in 2022, except that the term variant, instead of variant, we use the term subtype. Okay. So now coming to the major changes which have happened in 2022. First is nomenclature. The things to remember, bladder is comparatively easy as compared to RCCs. So this I have highlighted. So variants, instead of histological variant, use histological subtype. Two-tier system similar to 1998, 2004, 2016, and 2022, that is low grade and high grade. Apart from that, it's pretty much similar classification regarding the grading. In 2022, they have removed this term, tongue twister term, urethral proliferation of uncertain malignant potential, which is, I think, good because this particular term didn't mean anything to the clinician. It's a more confusing term. So now we have in non-invasive urethral tumors, you have dysplasia, you have carcinoma in situ, papilloma, inverted urethral papilloma, punlum, low-grade non-invasive papillary tumor, and high-grade non-invasive papillary tumor. So these are the terminologies which are recommended for non-invasive urothelial tumors. You have dysplasia, you have in situ, you have papilloma, inverted urethral papilloma, urethral neoplasm of low malignant potential, papillary urethral carcinoma low-grade and high-grade. Okay. And yeah, inverted urethral papilloma is addition in new WHO. And another thing I want to know, want everyone to remember is now that it's not all the urethral tumors will be either low grade and high grade. And in your practice, you see that many of the tumors will have mixed kind of heterogeneity is there in the morphology. Mixed morphology is there. Some areas are showing low grade, some areas showing high grade. So now WHO recommends this cutoff that if you are seeing heterogeneous tumor with low grade and high grade areas, if you have more than 5% high grade areas and predominantly low grade, so this particular tumor should be classified as high grade urethral carcinoma only. If it is less than 5% and is predominantly low grade, just add comment low grade with less than 5% area. So this is the recommendation. So 5% is the cutoff. More than 5%, straight away it goes into high grade. Less than 5%, add a comment. Less than 5% high grade areas are safe. Okay. So hyperplasia and U-pump is not recommended now. You can use dysplasia, reactive atypia, and carcinoma in situ. We will not go into details of how to pick up. So inverted papilloma is just like a papilloma which is growing inside. And you can have all grades of urothelial tumors in inverted fashion. That means you can have urothelial papilloma, urothelial neoplasm of low malignant potential inverted pattern. You can have low grade inverted urothelial carcinoma. You can have high grade inverted urothelial carcinoma. Okay. So we'll skip that. For infiltrating, it's essentially the same subtypes are there as they were in WHO. Staging is pretty much similar, nothing much has changed in bladder. The thing which has changed in bladder is it is addition of cytology now. Those who practice cytology or urine cytology know that now in urine cytology, the recommended terminologies to be used is according to the TPS, which has 7 categories. The Paris system for reporting cytology, and if you're doing urine cytology, you use these terminologies for the Paris system. Again, I will not go into the details. Another important thing in bladder is, which has come up now in last decade or so, is molecular classification. So what is this molecular classification? They say that low grade and high grade, they develop along to different set of pathways. And say low grade ones, they usually have this pathway of hyperplasia and dysplasia followed by FGFR alterations, and then your invasive carcinoma with FGFR3 alterations. Whereas high grade ones, they have dysplasia, carcinoma in situ, and usually the alterations in P53 and RB1. So this is the classical teaching of 2 different pathways of bladder tumors. So essentially, So along similar lines, in last decade or so, there were studies performed by three independent groups, which found out that MIBC, just like breast cancer, has intrinsic subtypes of basal and luminal, and these subtypes are easily distinguished on RNA expression profiling. They were validated by RT-PCR and immunohistochemistry, and they have proposed, like just like breast, even bladder is also can be divided into basal, luminal, and P53 type, and the various classification came up in last decade, dividing these bladder cancers into 3 or 4 molecular subtypes. Essentially, two main types were basal and luminal. So this is what I want you to remember from this talk, that in bladder also, just like breast, there is quite a good evidence now to show that they can be basal type or luminal type, and they have different pathways. The basal ones are the ones which are similar to basal layer of epithelium. They have P63 gene upregulation, activation of STAT3, overexpression of EGFR, whereas the luminal ones have PPR gene upregulation, FGFR mutation, and overexpression of E-cadherin. So this I've already told how you pick up basal first. Let's go with basal. Basal show expression signature similar to basal layer of normal urothelium. So they will show the biomarkers of basal cells like CK56, CK14, or CD44. Luminal ones, they are similar to the intermediate superficial layer of normal urothelium, and they will have signature of luminal cells, that is GATA3, CK20, and RB2 or HER2. And these groups which studied these intrinsic subtypes of bladder cancer also found that these type of urothelial carcinomas have different clinical outcomes. So the basal ones have the worst survival as compared to your luminal ones. So this we did in-house, and we found the similar studies. And apart from this survival and molecular characteristic, these type of bladder CAs, they say that are amenable to different type of therapies. So there are types like which are responsive to neoadjuvant chemotherapy. There are types which are responsive to FGFR inhibitors, luminal papillary type, and luminal non-specific site are more responsive to immune checkpoint inhibitors, whereas basal ones are more responsive to EGFR inhibitors. So rather than just giving cisplatin to all the aggressive bladder tumors, now there is diversification of treatment of bladder cancers, and they say that different molecular subtypes are responsive to different treatments. So whatever, the classification has obviously expanded with multiple groups coming up and finding different findings. There have been subcategories of luminal also into various types. We also at our institute have done multiple studies and found that different molecular subtypes exist, and for the classifications in multiple cohorts. So we have our work in the literature. But the main thing which you have to remember is whatever with the classification, two basic intrinsic types in bladder cancer molecular classification are luminal and basal. Okay, so that is this thing. And as I told you, why this subtype is important, because we have different therapeutic targets. Okay. And also with the emergence of PD-L1 therapy, you all know the anti-PD-L1 is approved by FDA for advanced bladder cancer. So there is also a specific criteria how to do the PD-L1 testing in bladder cancer. If you want to go to read about the detail, you can go in this paper which we published couple of years back, in which PD-L1 testing and immunotherapy has been recommended, the best practice recommendation. So you have different assays. Those who use PD-L1 know that different assays and different platforms can be used. Another thing which has come up in bladder is FGFR gene alterations. So they say that FGFR mutations are seen in couple of muscle invasive bladder cancers, and now anti-FGFR inhibitors are recommended for advanced bladder cancer. Hence, it's important to check for FGFR mutations in bladder cancer also. So you can go for the molecular classification on the basal luminal, check for FGFR inhibitors, go for anti-PD-L1, and also in case some of the bladder cancers, especially the ureter ones, urothelial cancer, they are associated with Lynch syndrome. So you should check for MSI. MSI, can be tested either by IHC or by your molecular this thing, we have this standard 6-panel IHC, which is well standardized, which you do in your GI also. The same panel can be used in bladder to pick up microsatellite instability in bladder. So this is our work, which has been published in Modern Pathology and was presented at ASCAP on FGFR and MSI in bladder cancer. So from bladder, I think I want you to remember only two things. One is that you should, when you're writing the report and you're seeing any kind of different morphology, don't write variant, just write subtype. And if possible, if you are dealing with the high urology output setting, you should do the molecular subtyping. So this is our group, which is a Society of the Nitrogen Pathology. It is a society open to all members. And if you're interested in learning more about geopathology, this is a pan-India society with multiple big centers from across the India, Tata, Calcutta, TMH, Mumbai, and Chennai. So we have expert consultants from all over India. You can be part of the society and learn more about geopath. We keep on doing annual conferences every year at different places. And I think that's all from my side. And if there are any questions, I am more than happy to answer. Thank you. You can stop sharing, I guess, Aman. Are there any questions? Any of the participants? Are there any questions in the chat? Okay, so yeah, if you have any, you can still email me. You have my ID. You can take it from the organizers if you want to get back to me with any queries. My phone number and my email ID is there with the organizers. And all right, if there are no more questions, I think we can close the session. Thank you, Aman.
My name is Dr. Anju Singh Kaura, and today we present DFSP, dermatofibrosarcoma protuberans. It's a rare superficial low-grade, locally invasive soft tissue sarcoma and accounts for less than 0.1% of all soft tissue malignancies and less than 1% of all soft tissue tumors. It is derived from dermal fibroblast and has an increased rate of local recurrence, although smaller risk of distant metastasis. So pathological finding, we see FNA smear, revealed cellular aspirate showing spindle cell in cluster and in story-form patterns. So having elongated uniform nuclei with mild pleomorphism, patient underwent surgical rejection and grossly a skin-covered mass with received measuring 12 into 4 into 4.5 into 3.5 centimeters. So cut surface, we saw the well circumscribed nodular whitish glistening tumor. And microscopically features were suggested of pleomorphic spindle cell sarcoma. On ISC cell, the show the positivity for CD34, pachyllosis, and the CD163 and CD68, confirming the diagnosis of DFSP. So now discussion we start will be DFSP is a rare but challenging skin lesion. It is a superficial, slow-growing malignant fibroblastic mesenchymal skin tumor and frequently occurring in a middle age group. So histologically, it is composed of monomorphous spindle cell arranged in a story-form growth pattern. So now conclusion is DFSP has a locally invasive potential and high recurrence rate, thus a good clinical radiological acumen and a cytology histologically and immunohistochemistry workup is needed for accurate diagnosis, treatment, and long-term follow-up so they patient any recurrence. So in this condition, and a material and a matter is नहीं disconnect हो गया.
No, it's not disconnected.
We can hear you. We can hear you.
Yes,
Continue.
yes, yes. So material and method is slide. So sorry. An 80-year male presented with a large mass over anterior aspect of left mid thigh. Yeah. So material and method is in this condition, and dermatofibrosarcoma protuberans. So now it will be include a case of 80-year male presented with a large exophytic mass over the anterior aspect of left mid thigh. On examination, mass were ovoid and firm fixed, patient without localization and heat and redness. So MRI reveal a large 9.4 into 4.2 and 3.2 centimeter lobulated heterogeneous single intensity soft tissue masses. So now in this case, we were conclusion is a DFFC is a locally invasive, potential and high recurrence rate, thus a good clinico-radiological acumen. So cytology, histopathologically and immunohistochemistry workup is needed for accurate diagnosis. So treatment and long-term follow-up of these patients for any recurrence. Now,
Okay. Is the presentation over?
yes, ma'am.
Okay. So what was the diagnostic challenge in this case for you?
This is a rare but a challenging skin lesion because a superficial and slow growing malignant fibroblastic mesenchymal skin tumor. Frequently, mostly ma'am seen in middle age groups. So
Why did you say this is challenging for you?
challenging, ma'am, this is a rare, very rare, and so less than.
Rare on this. So how did the imaging modality help you in this?
And when they
Dr. Andrew, you've muted yourself.
sorry.
So, ma'am asked, how did the imaging help you?
CT MRI is showing demarcations and some patient and surface and in the story patterns to some.
But we cannot see the story form pattern in imaging now.
No, ma'am, no.
Okay.
Dr. Andrew, it was an interesting case. You're a junior resident, right?
Yes, ma'am.
Which year?
Second year.
Okay, well presented. I just have a question for you. How do you differentiate DFSP from dermatofibroma?
Ma'am, two condition be differentiated because first is a age grouping, and because of DFSP is mainly middle age groups, but any others are any occurring age. And second is we will differentiate in monomorphous population of like spindle cells, but other is no monomorphous.
So dermatofibroma is not monomorphous, is that so?
मतलब rare हो maybe.
Okay. Anything else? Is there any difference in the epidermal changes of the two tumors? Anything with the IHC?
I see. Yes, ma'am. And Marcus differentiates is then ISC CD34 in positive in this cases, but any others are not positive.
Is there any particular staining pattern of CD34 in dermatofibroma? And what
Patchy
are
losses. So patchy losses on ISC has a so positivity for CD34 in patchy losses in this condition.
also my question is, can CD34 help you in differentiating DFSP from dermatofibroma?
Yes, ma'am. We will differentiate.
Okay, so how does the CD34 pattern on dermatofibroma look like?
Yes, ma'am. One.
That's okay. I think, Saraswati ma'am, is it okay if we move ahead?
Yes, please. Let's
Okay.
move ahead.
Okay. I think we have another presentation from Dr. Anju. Should we proceed with that, ma'am?
Yes, let her
Okay.
finish both. Yes.
Dr. Anju, you can proceed with the
Yes, ma'am.
second presentation on ovarian fibroma with
Yes,
serosystema.
ma'am. Yes, ma'am. कैसे करेंगे जून में सेकेंड मतलब 14 इसमें फिर अपन को वो वाला हाँ पर सेकेंड वाला कैसे करेंगे उसके वाला वो आएगा ना हम्म, तो इधर था वो पर ये वाला नहीं है वो अपने न्यू फोल्डर में डाला था.
Dr. Anju,
Yes, ma'am. Yes, ma'am. We
will you
will
please
connect. Yes, ma'am. Screen share and न्यू फोल्डर था अपना ये वाला इसमें 15.
Dr. Anju, please open your camera.
Yes. ये वाला नहीं था ये था स्टार्टिंग है ना. Enable editing and slideshow. So we start next poster in my is a surface epithelial. फिर से स्टार्ट ये गड़बड़ हो रहा है ना कुछ. So now we will start a ovarian fibroma with serous cyst adenoma. This is a rare
Dr.
combination.
Anju, sorry to interrupt. So you've not shared your whole screen. Can you share your whole screen so we'll be able to see the poster?
Yes, ma'am. I will share a whole screen.
Okay.
So first we start with a introduction and surface epithelial stromal tumor, the most
Dear,
common
your
neoplasm.
poster is still not
we
visible.
cannot see it, Anju.
क्या करना है यहाँ
Open your presentation, please.
स्टार्ट नहीं हो रहा ना. इनेबल है ना ये तो यहाँ से छोड़ो.
मैम आप दोबारा से क्लोज
यस यस सर
करके और दोबारा पीपीटी
हाँ
खोलिए।
वो थोड़ा प्रॉब्लम हो रहा है इसमें बोलेंगे ये सेकंड नंबर 15 नंबर इस पे शेयर तो होगा ना इनेबल एडिटिंग का और फिर देन इस पे क्यों नहीं आ रहा है
Ma'am, should we proceed with Dr. Harshita in the meanwhile?
Maybe to save time, it will be
Ji, ma'am.
better. Thank you.
So is Dr. Harshita around?
यस मैम
Okay, maybe you can start with your presentation while Dr. Anju can figure out the little technical glitch that she's having, okay? Dr.
Yes,
Anju, you
ma'am.
can take a little time, okay?
यस मैम मैम जस्ट 1 minute
Sure.
मैम इज इट विजिबल टू यू
No, no, not yet. We can see your screen and we can see that you're trying to open a poster PPT, but the poster is not visible yet.
Ma'am, it is in PPT form. Means 7 slides are there. Should I open my poster form?
I think open your poster, yeah?
Okay, ma'am. Sure. अलग किया था डेस्कटॉप पे पीसी पे करा था डेस्कटॉप पे सेव था ना इस पे कैसे करेंगे वही दिक्कत हो रही है ना क्या स्टार्ट क्यों नहीं हुआ पहले हमने करा था ना उससे मैम नाउ इज इट विजिबल
नो मैम, नहीं दिख
No, nothing.
रहा कुछ भी।
The screen is not shared, I guess. Anju, yes, we can see your poster on Epilus.
Yes, ma'am.
You can start
Ma'am,
presenting.
can I start?
Yes, Harshita, you can present.
My presentation topic is a rare case of congenital epulis. Firstly, the introduction. It is a benign tumor of oral cavity, is an extremely rare condition in newborn. It is 3 times more common in maxillary alveolus than mandible. Method is a 3 days old child, female child, present with swelling in the left side of jaw since birth. Grossly, it is 2 whitish nodular firm tissue mass. Larger piece measures 2 into 1.5 into 0.7 centimeter. Microscopy. Sections show tissue bits lined by stratified squamous epithelium. Underlying encapsulated lesion show large polygonal cells arranged in sheets with having granular eosinophilic cytoplasm with small central nuclei. Now, in this image, we see 2 soft tissue masses, and in microscopy, which is run on 400x, we see large polygonal cells arranged in sheets having granular eosinophilic cytoplasm with small central nuclei. Now, the discussion. Congenital epulis is commonly found in neonates as a mass derived from gingiva with female preponderance is more, that is 8:1. Differential diagnosis includes epicanthus, hemangioma, fibroma, hemangioma. Epiphyseal tumor have mesenchymal and odontogenic origin. Tumor cells were reactive for CD68, a macrophage marker, but did not react with S100 protein, which support different cells of origin. Conclusion is congenital epulis may regress spontaneously, but immediate intervention is required if it is obstructing the airway passage in causing difficulty in feeding. My references are these. Thank you, ma'am. Ma'am, I'm done. Hello, ma'am.
Hello.
Hello, ma'am. Am I audible?
Yes, you are audible.
Ma'am, I'm
So,
done.
yes. So, what are the highlights of this case? Like, why did you find this presentable in the poster?
Ma'am, it is mainly a rare benign tumor. We do not have to do anything if it is few, means it is found a few millimeters to centimeters sometimes. So if it is few millimeters and it is not causing any problem in the child, if it is obstructing the airway, then only uh, we need to do the surgery for it, and otherwise it regresses spontaneously, so we
Did
do
you
not need to do any intervention.
did you have any other differential diagnosis while you were diagnosing? I see you have done IHC and all that.
Yes,
What
ma'am.
else did you have in mind? What did you want to rule out?
Means, ma'am, differential diagnosis.
Uh-huh.
Ma'am, are you asking differential diagnosis?
Yes, yes, yes.
Ma'am, it may be differentiated with lymphangioma,
Mm-hmm.
hemangioma, or means is hemangioma means cavernous hemangioma, or capillary hemangioma.
Did the morphology of was it confused with any of these processes?
Yes, ma'am, epicanthus, maybe it will confuse with this.
In this case,
Sorry, ma'am, please repeat.
in this case, I'm asking. So you said you
In this-
found tissue bits lined by stratified squamous epithelium, and it was
Yes, ma'am.
encapsulated with large polygonal cells with
Yes, ma'am.
eosinophilic cytoplasm.
Yes,
So
ma'am.
what would you think of? Will you think of hemangioma and lymphangioma and all in that case?
Ma'am, maybe
Hmm.
other things may be possible.
What are the other things?
Mm,
That is what I'm trying to ask you. At this age,
At this age means in
so
newborns.
keeping in mind the age, the morphology,
Yes,
why
ma'am.
did you do the IHC? What were you thinking of? What did you want to confirm or what did you want to rule out?
Ma'am, maybe any tumor is there.
वही है बाबा कौन सा ट्यूमर
Ma'am, squamous cell carcinoma.
in this child like a 3-day-old child you will think of a squamous cell carcinoma.
Ma'am, I'm not sure about it.
Okay, no problem.
So, Dr. Harshita, had the case been positive for S100, what would have your diagnosis changed?
Ma'am, it was means origin may be different for it. Means it may be mesenchymal or odontogenic origin. We will differentiate it with
And
S100.
if S100 was positive with this morphology, what would you sign it out as?
Sorry, ma'am, don't know the answer.
That's okay. Read about it. It's an interesting case. Thank you.
Thank you, ma'am.
We can move on to the next presentation. If Anju is ready, we can have hers.
Yes, ma'am. Yes, ma'am, she is ready.
We have Dr. Anju now presenting ovarian
Yes,
fibroma
ma'am.
with serous cyst adenoma.
Yes.
Ma'am, just a second. Just a minute. Yes, yes. Again. Slide so. It is visible, ma'am. Ma'am, is it visible to you?
Yes, please proceed.
It is visible, yes.
Yes, ma'am. My poster is a ovarian fibroma with serous cyst adenoma and a rare combination. So start with introduction. Now, surface epithelium stromal tumor, the most common neoplasm of the ovary, encompasses 5 distinct subtypes. These are first is serous, second is mucinous, then endometrioid, clear cells, and transitional cells, along with combination of these types. So tumor with serous differentiation represent 46%, and all surface epithelial stromal ovarian neoplasm, sex and stromal tumors account for 8% of all ovarian tumors, fibroma being the commonest. The tumor at all stages of peak in a perimenopausal age and are mostly benign. And here we report a case of benign solid and cystic tumor of the ovary, which show a combination of ovarian fibroma with a serous cyst adenoma. This is a rare combination. So now start a pathological finding. Gross pathology is a right ovary measuring 30 into 5, 15 into 15 centimeter, mostly cystic, so a large multilocular thin-walled cyst containing hemorrhagic serous fluid. Capsule is intact all over. One solid area measuring 12 into 8 into 7 centimeter. Inner cyst wall is smooth all over and no papillary projection seen. Now see a figure A. This is a gross. And microscopy, right ovarian mass section from cyst show fibrous cyst wall, mostly denuded and flattened epithelial lining. This is figure B. And section from solid area show cell with ovoid to spindly bland nuclei arranged in intersecting bundle with fibrous stroma. Now we can figure number C. And area of edema with dilated blood vessels, so in figure D, no evidence of atypia and malignancy. Now we start as a discussion. So a clinical, because of a presence of solid and cystic component, the tumor may be mistaken as malignancy and the radical surgery may be done. Awareness of the combination may help in avoiding such mismatched, both component being benign, excision in is curative. And material and method is also 60-year-old female patient with chief complaint of abdominal pain and distension, increased frequency of micturition and constipation. Now per abdominal examination of her mobile mass of around 26 to 28 week size with smooth surface bar revealed. On per speculum examination, third degree UV prolapse with cystocele and rectocele C. So in last, the conclusion is we are reporting these cases for creating awareness among the pathologists and gynecologists about the occurrence of this rare combination of ovarian tumor, so that misdiagnosis and mismanagement can be avoided. So, yes, ma'am.
Is it done, Dr. Anju?
Yes, ma'am, be done.
Okay. But okay, I just have a question. How did
Yes,
the
ma'am.
presents ovarian fibroma and serous adenoma both are so how did this presence affect your diagnosis?
Ma'am, this is a rare, but ma'am, combination is very rare combination, ma'am,
Was
because
there an- Mhm.
serous cyst adenoma with ovarian fibroma. This is a very rare.
You said there was a solid area, right?
Yes, ma'am. Yes,
So that solid area was the one that showed fibroma.
yes,
When do you call a serous adenoma cystadenofibroma?
yes, ma'am.
When do you call it? When like
Ma'am, cyst adenoma is a cystic changes.
no? What is
Serous.
a cystadenofibroma? There is
Ma'am,
something called as a serous cystadenofibroma.
yes, ma'am.
Okay.
Ji.
How is the morphology of that lesion? What is the morphology of that lesion?
Morphology is a multilocular, thin-walled cyst, large sizes, and mostly cystic sores, and containing a hemorrhagic fluid, serous
So
fluid.
what is the difference between a cystadenoma and a cystadenofibroma?
Cyst, proper cyst, adeno.
Fibroma. Cystadenoma versus cystadenofibroma. What is the difference?
Ma'am, flattened epithelium and also lining a differentiated
वो
condition.
तो ठीक है.
Yes.
उसके बाद
Then second is spindly bland nuclei in intersecting bundles with a fibrous stomas, and blood vessels like edema.
no, no, that's not what I'm looking for. It's okay.
Yes, ma'am. Okay.
You read up what is a cystadenofibroma, okay?
Yes, sir. Okay.
Dr. Anju, what are the other sex cord stromal tumors that you know of?
Other sex, Sertoli cell tumors and teratomas.
Sorry?
Leading cell sex stromal tumors, ma'am.
Yeah. You said Sertoli cell tumors and
Leading cell tumors,
Leydig cell tumor, okay?
in granulosa cell tumor,
Okay,
and stromal cell, fibroma, thecoma, like.
great. Okay, thank you.
Okay, ma'am. Thank you.
Okay. Dr. Divya, can we proceed to the next presentation by Anju?
Yes, ma'am.
Yes, ma'am. Yes, ma'am. We will take 2
So we
minutes.
now have a presentation by Dr. Anju on ALCL, a case
Yes,
report.
ma'am. Ah, 17. Ma'am, visible?
Yes, it's visible. Please make it to
Yes,
close.
ma'am. And now anaplastic large cell lymphoma, a rare form of non-Hodgkin lymphoma. So we will start in pathological finding. So FNA from lateral and anaplastic large cell lymphoma, ALCL, a rare form of non-Hodgkin lymphoma. So pathological finding in a FNA smear. So from lateral, and first is material method is a 32-year-old male present with chief complaint of fever, abdomen distension, presented with abrupt onset of swelling of right inguinal region, 15 days duration. And now examination enlarge multiple lymph nodes swelling with different sizes. So pathological finding in FNA smear from lateral and medial side of right inguinal region, measuring is 7 into 4 centimeter, is firm, non-mobile, non-tender lymph node. FNA smear are cellular, so large to intermediate cell, so marked pleomorphism, high NSU ratio, prominent nucleoli, coarse clumped irregular nuclear border, hyperchromatic nuclei, and moderate bluish cytoplasm. So gross finding in this case, single grayish white firm tissue mass measuring 5.5 into 3.7 into 1.8 centimeter. And microscopy is multiple section show diverse morphological spectrum, completely diffuse cohesive sheets of anaplastic large cells that have horseshoe or hallmark cell, figure C. Now we can see, and breath like a multiple nuclei, perinuclear eosinophilic region, occasional nuclear pseudo inclusion, dognut cells, rare mitotic activity. And ISC were also done in CD30, ELK1, PAX5, CD15 now, and are suggestive for categorization. And now discussion is it is a type of non-Hodgkin lymphoma that a feature of WHO classification of lymphoma. Defining feature consists of a proliferation of predominantly large lymphoid cells with strong expression of cytokine receptor CD30 and characteristic growth pattern. So now anaplastic large cell lymphoma is a rare type of non-Hodgkin lymphoma, which is characterized by peripheral, mediastinal or abdominal lymph nodes involvement, and is confirmed by FNAC and histopathology or ISC. So FNA finding is this, and histologically is a microscopy this can see. So figure A, ISC CD20, and figure B, HA stain 20X, and C in hallmark cells. And so, ma'am, this is a large cell lymphoma, is a rare type of non-Hodgkin lymphoma.
Dr. Anshu, is it just about being large, or what is the thing that made you call it anaplastic large?
Oh, ma'am, anaplastic.
Now, why did you call it anaplastic large? We have already highlighted
yes,
it.
Yes, ma'am. Yes, ma'am. Horseshoe and dognut cells is microscopy we will see. So, and look very different, ma'am. So,
and dietary wise, what makes it?
Cytokine receptor CD30 expression. The strong expression of the cytokine receptor. So CD30. And growth pattern.
What does CD stand for, Anju?
Yes, ma'am.
What does CD stand for?
CD10.
No, the alphabet CD, right? What does it tell you? What is the expansion of CD?
Yes, I do also. Cluster of differentiation of the CD.
Cluster of differentiation.
Yes.
Dr. Anju, can you interpret this CD20 slide for me that you have put?
CD20.
You put an IHC na CD20 figure A में.
30 exactly.
Sorry.
Sorry. CD20 to review first. Sir, ma'am, this is a figure ISC CD20. Yes,
Yeah.
it's
Can you
positive.
indicate?
Yes.
It is positive in which cells?
Yes, ma'am. Categorization for suggested for categorizations.
So can you interpret the CD20 slide for me? If it is positive or negative, and if positive, it is positive in which cells?
Color differentiation. So
In which cells is CD20 positive?
anaplastic cells. So dog nuts.
Okay, so can you tell me if which of these is a T cell marker and which of these is a B cell marker? The list that you've provided here of these, which is a T cell marker and which is a B cell marker?
B. Sorry, ma'am. Okay.
That's okay. I don't need to see the PPT. Could you tell me which is a T cell marker and which is a B cell marker?
So B cells marker, but I'm not sure. B.
Okay, and anaplastic large cell lymphoma is a B cell lymphoma or a T cell lymphoma? That's okay. So, I really appreciate that you've taken out the time and put in the effort to present three interesting cases. Just a little feedback, try to read about the cases. These are interesting cases. You should be able to read about them before you present your poster, so that will help you learn a lot more from the exercise. Great
Yes,
job. Thank
ma'am.
you.
Yes, ma'am.
Thank you.
Thank you.
Ma'am, should we proceed with the last
Yes,
presenter?
yes, yes.
Okay, so we
Dhiren.
have Dr. Dhirendra Kumar presenting a cytomorphology of Phyllodes tumor of breast. Dr. Dhirendra, please.
Hello. Hello.
Yeah, you're audible.
Yes, you are audible.
Just 10 seconds. Post disablement. It shows post disabled participants screening sale. Post disable.
मैंने आपको कोहोस्ट बना दिया है, आप शेयर कीजिए स्क्रीन।
Okay. Okay. Good afternoon. Myself, Dr. Dhiren. I am presenting on a topic of presentation, cytomorphology of phylloid tumor of breast. Introduction. Phylloid tumors means leaf-like in Greek. Describe the unique papillary projection characteristics of phylloid tumors on histology. Phylloid tumors are a rare type of biphasic fibroepithelial mass that form from the periductal stromal and epithelial cell of the breast. They account for less than 1% of all breast neoplasms. They were previously termed uh, cystosarcoma phylloids, coined by Janus Muller in 1838, before being named to phylloid tumors by the World Health Organization in 2003. Case presentation. A 40-year-old female presented with a painful large hard lump in the right breast that was progressively growing since 2 years. She also had along heaviness and pain in the breast. Radiological findings were suggestive of phylloid tumors and advised FNAC. Cytological report. On gross examination, there is 6 into 5 centimeter large swelling in right breast, hard in consistency and slightly mobile. In microscopy feature, FNA smear are highly cellular, so round to oval ductal cells arranged in monomorphic folded sheath intermingled in myoepithelial cell, many stromal fragment and discrete oval to spindle cell in background, cluster of apocrine cell and foamy macrophage admixed with RBCs. Final diagnosis on FNAC feature are suggestive of fly tumors and confirmed by the histo reports, which suggestive of benign flush tumors. Discussion: diagnosis of fly tumors by FNAC is difficult as it is unreliable in distinguishes uh, uh, PTs from fibroadenoma, criteria phylloid tumors from fibroadenoma, criteria for the diagnosis of benign phylloid tumor, including at least 2 large stromal fragments, hypercellular fragments, and moderate to large number of dissociated stromal cells. Fibroadenomas and phylloid tumors share a dimorphic pattern and both epithelial and stromal component. The distinguishing feature related to the stroma, including the presence of hypercellular stromal fragments, cellularity of background nuclei, and cellular composition and morphology of background nuclei. The phylloid tumors are classified into 3 types on basis of histopathology as benign, borderline, and malignant. These are the reference. Okay, ma'am.
Okay.
Yes, ma'am.
So how does this cytological diagnosis contribute to clinical management?
Yes, ma'am. Sorry, ma'am.
How does the cytological diagnosis help in the clinical management? Especially apart from phyllodes, what is the other fibroepithelial tumor which we have difficulty to distinguish from?
मैम रिकरेंस ज्यादा होने के चांस होते हैं इसके, तो इसके लिए साइटोलॉजी
ठीक है। ये सेम मॉर्फोलॉजी है ना जो साइटोलॉजी में अभी दिख रहा है, वो
Yes, ma'am.
एक और ट्यूमर दिखा सकते हैं, है ना? व्हाट इज द नेम ऑफ
Yes,
दैट?
ma'am.
फाइब्रोएपिथेलियल ट्यूमर।
फाइब्रोएडिनोमा।
हाँ, वो ही। तो अभी जो साइटोलॉजी
Yes,
में
ma'am.
डायग्नोसिस हुआ है वो मैनेजमेंट में कैसे हेल्प होगा?
मैनेजमेंट में सर्जिकल एक्सीजन मींस मैम इसको प्रॉपर करना पड़ेगा, तो ये ताकि रिकरेंस ना हो, और इसका मैलिग्नेंट रेयर होता है पर हो सकता है 1%
मैलिग्नेंट
चांस।
में कैसे डायग्नोसिस कर सकते हैं फिलोड्स में? अगर वो मैलिग्नेंट फिलोड्स है तो उसके लिए क्राइटेरिया क्या है?
उसके लिए मैम मार्क्ड हाइपर सेलुलरिटी होगी, माइटोटिक फिगर मिलेंगे जो कि मोर देन 5/10 हाई पावर फील्ड होंगे, और नेक्स्ट में सेलुलर अरेंजमेंट जो होगा नेक्स्ट पैटर्न में मिलेगा, एंड एटीपिया ज्यादा होगा, माइटोटिक फिगर होंगे, एटीपिया ज्यादा।
ये सब आपको साइटोलॉजी में भी दिखा सकती है ना?
यस मैम, बिजार सेल्स कुछ एटीपिया मिल सकता है मैम।
और जो हाइपरसेलुलरिटी आपने बोला वो कहाँ पे होगा? ये एपिथेलियम में होगा या स्ट्रोमा में होगा?
स्टोमल सेगमेंट में, स्टोमल फ्रैगमेंट।
गुड,
थैंक यू मैम।
So, Dr. Dikendra, what will happen if you, what will be the management if you diagnose this as a malignant phyllodes on cytology, or if you suspect a malignant phyllodes on cytology?
मैम MRI means
Right. And
complete
what
surgical
intermediate phyllodes? Borderline phyllodes?
for borderline surgical excision and no ma'am, management. Sorry ma'am.
So they do a wider excision, just a wide local excision versus a lumpectomy for a benign phyllodes, and as you said, MRI for a bioplasty for a malignant phyllodes. How to differentiate malignant phyllodes from a primary sarcoma of the breast?
Malignant phylloid versus
Sarcoma of the breast. A primary
sarcoma
sarcoma.
of the blood.
Yeah. Because both of them will look like malignant looking spindle cell lesions, right?
Atypical epithelial cells होंगी मैम इसमें साफ
किसमें?
एटिपिकल epithelial cells नहीं मिलेंगे
किसमें? sarcoma में या phyllodes?
sarcoma.
And phyllodes में you will find atypical epithelial cells or something else? You're partially right. But why do you think phyllodes,
Yes,
why do you think phyllodes will have atypical epithelial cells? Phyllodes के epithelial cells atypical होते हैं या benign होते हैं?
benign.
Benign, okay, right? So in a case of where you're thinking of malignant phyllodes, if you find benign appearing epithelial cells, that supports that it is more likely to be phyllodes. Okay? And you call a tumor as a primary sarcoma of the breast only if you have sampled it extensively and you still don't find any epithelial cells. Well presented. Thank you.
Okay, thank you, ma'am.
Dr. Divya, I think.
Thank you.
Thank you, Dr. Dhirendra. Nice
Thank you,
present.
ma'am. Thank you.
So, Dr. Divya, we can wind up our session, right?
Right. Thank you all the presenters for being here, and thank you Saraswati ma'am for being the judge. Thank you so much, everybody.
Thank you, Dr. Divya.
Thank you.